And welcome back. We are moving on to chapter 28, the head and spine injuries. So, as you'd assume, this chapter really focuses on injuries of the head and the spine, right? These are both areas that protect the brain, the spinal cord, and the various nerve pathways that really control the entire body. Now, any injury to these areas can have an effect on a patient's consciousness, their movement patterns, sensation, their breathing, circulation. Um, and a lot of these can have very visible damages that you can actually see. Okay. So we're going to begin this with some basic anatomy review and then connect that foundation to just common injury patterns, your patient assessment, and then finally, what emergency care interventions you can provide and what transport decisions there are to be had. Now, the nervous system itself is the body's communication and control system, right? So this is going to include the brain, the spinal cord, the billion of nerves that travel throughout the entire body. Now, the brain itself receives information and decides how the body should actually respond, whereas the spinal cord carries those messages between the brain and the rest of the body, while the smaller nerves extend into the skin, the muscles, and into the organs. Right. So this system allows us to think, feel pain, recognize temperatures, pressures, move our muscles, and respond to what is happening in the world around us. Okay. It also helps us control essential functions that continue without conscious effort, which includes your breathing and a lot of your heart activity. Now, because the nervous system is so vitally important, right, the body gives it substantial amounts of protection. Okay, so the brain sits inside the skull, and the spinal cord actually runs through the spinal canal that's formed by your vertebrae. Okay, now these bony structures really do a good job absorbing and spreading many of the forces that we experience during normal activities of daily living. Now, their protection still has limits, though, right? So, a strong impact, any sudden change in movement, a penetrating injury can all damage those nervous tissues that are deep inside. Okay, and those damages, unfortunately, can be hidden. So, a patient can have bleeding, swelling, or some type of spinal injury, even when there's no dramatic wound on the surface of the skin. Okay, so this is why the mechanism of injury, changes in the neurological function matter so much throughout your entire assessment. So let's break down the nervous system a little bit more. So the nervous system is divided into two main anatomical parts, right? So you have the central nervous system and the peripheral nervous system. So the central nervous system, or we can call the CNS, this consists of the brain and the spinal cord. It serves really as the main processing and coordinating center of the body. Whereas the peripheral nervous system, or the PNS rather, so this is going to include the nerves that extend from the brain and the spinal cord into the rest of the body. Now, these nerves are going to carry information towards the central nervous system and then carry instructions back to the muscles and the organs. Now, these two divisions are described separately for learning purposes, but really they function together as one connected system. So if we look at this image, we can follow the directions of the arrows in the diagram. So you have a sensory message that begins in the body, right? So if we look at how the skin can detect pressure or temperature, touch, pain, heat, that message is going to travel through the peripheral nerve towards the spinal cord and the brain. Now, after that information is processed, a motor message travels in the opposite direction. So it moves from the central nervous system through a peripheral nerve to a muscle that's going to actually produce the movement. Okay. So this basic pattern is very straightforward. You know, sensory information travels in and motor instruction travels out. Any injury anywhere along this pathway can have an effect on what the patient feels, how they move, or both. Okay. So that's why it's important. That's why it's really important to understand why movement and sensations are assessed separately during your neurological examination, which we'll cover a little bit later. Um, so the central nervous system, again, to recap, is the brain and spinal cord, right? So together they're going to receive that information, they're going to organize it, they're going to coordinate it, and then make a and essentially organize and coordinate it to a body kind of response. Now, the brain is also the center of your consciousness. Okay, so the consciousness includes, being awake, aware of what's happening, and able just to think and respond appropriately to your environment around you. Okay, so a change in consciousness after trauma can also be an early sign that the brain is no longer functioning as it should. Right. So it's really important to understand, just at least for educational purposes, that the brain anatomy is divided into three major areas, right? So you have the cerebrum, the cerebellum, and the brainstem. Okay, each of these has a different primary role, but again, they all work together continuously. Um, so here we have the cutaway. We can actually see these different divides, right? So the cerebrum is the largest. It's kind of folded portion that occupies, again, the bigger portion of the skull. The cerebellum here sits a little bit lower towards the back, and while the brainstem here lies at the base and continues into the spinal cord through the foramen magnum. Okay. Now, the cerebrum itself is divided into two lobes. The frontal lobe is associated more with judgment, behavior, voluntary movement. You have the parietal lobe, helps us really process bodily sensations and your spatial awareness. Then you have the temporal lobe, which is involved in hearing, memory, language, and then the occipital lobe is more has to do with your vision. Okay, these regions function together, but again, their locations just helps us understand why an injury may produce a particular neurological change. Like we talked about, the cerebrum is again the largest part of the brain. Okay, it accounts for about 75% of its total volume. It can be divided also into a left and right hemisphere. Okay, but again, they're divided, but they work really close together. The cerebrum itself responsible for again voluntary motor function, and that voluntary movement just means an action we choose to perform, like walking, speaking, raising your arms. But it also supports conscious thought, including your memory, your reasoning skills, language, judgment, and emotion. Now, because of these kind of varied roles, an injury to the cerebrum may appear, as weakness, confusion, maybe memory loss, speech difficulty, or a change in behavior. So it can be very diverse in how the patient may present. Then we have the cerebellum. Again, helps coordinate balance and movement. It's more about fine tunes and the timing and accuracy of an action. So it allows movement to remain like more smooth and controlled. So an injury in this area may lead to like poor balance, an unsteady kind of gait pattern, and just clumsy movement overall. Now, the brainstem controls many of those functions that continue automatically, that we don't need to consciously think about. And the biggest ones are going to be your breathing and a lot of your heart activity. Now, it also helps maintain your overall alertness and connects the higher parts of the brain with the spinal cord. Now, although the brainstem sits a little deeper within the skull, it is very protected. But pressure or injury affecting it could actually be very dangerous because, again, this is what controls some of those more basic life functions. So the patient actually can deteriorate fairly quickly if there's an injury to that area or if there's any increased pressure to that area. Now your spinal cord. So your spinal cord really extends down from the brainstem, and again, that carries information between the brain and the body. So within that cord, you have something called gray matter and white matter. Okay, gray matter contains nerve cell bodies and synapses, which are the junctions where nerve cells can communicate. Then you have the white matter, and it's formed mainly from like long fiber pathways that carry signals up and down the spinal cord. So these pathways handle different types of information. So depending on where the cord is injured, the patient may lose movement, sensation, or both below that affected area. Okay. Also, the muscles may still be physically intact, but again, it's just the instructions from the brain are no longer able to actually reach them. Now, the brain and spinal cord, again, they sit behind a lot of protection. Okay, so you have skin, connective tissue, muscle, bone. Those all help absorb forces and form a barrier against infection. But now beneath those layers is the central nervous system is kind of wrapped in these three membranes that we're going to call meninges. Okay, now these membranes provide just added support around that very, very delicate nervous tissue. Okay, their names and positions are going to be clinically important later on because bleeding inside the skull is classified according to the layer or the space in which that blood is going to start collecting. So let's kind of talk about those three spaces. So from the outside going inward, you have the first meningeal layer, and that's called a dura mater. Okay, so this is like a thick, tough fiber, and it lies more towards the inside of the skull. Now, beneath the dura, you have the arachnoid mater. So the subdural space that is going to be between those two layers, and that's what's going to be inside. It's going to be our bridging veins, which can tear when the brain moves forcefully inside the skull. Then we have the pia mater, and this is going to be the most innermost layer, and it rests directly against the brain. So between the arachnoid and the pia is the subarachnoid space, which contains again more blood vessels and something called cerebral spinal fluid. Okay. Now, just a useful kind of memory aid in this is that sub means beneath. Okay, so subdural means beneath the dura, and subarachnoid is beneath the arachnoid. Okay, makes sense. Perfect. So if we look at the cross section of the skull, from the outside towards the brain, we can pass through the skin, the fascia, the muscles, the skull before we reach the actual meninges. So the dura, again, from this image, is inside the skull, right? Immediately inside the skull. Beneath it, you have the arachnoid layer, then the fluid-filled subarachnoid space, and then the pia resting against the brain tissue. Now, once again, the relationship between these is very important, and the relationship between the brain, because it's separated from the skull by several protective layers, and again, that cerebral spinal fluid. So, when trauma damages a blood vessel, the location of the bleed within those layers just helps determine the type of injury and how quickly that patient can potentially deteriorate. So cerebral spinal fluid, we can also call this CSF. So this is really a clear fluid that's produced inside the chambers of the brain called ventricles. Okay. Now, at any given time, there's approximately 125 to 150 milliliters that surrounds the brain and the spinal cord. The CSF really does a good job cushioning and nourishing the nerve tissues. So any type of severe trauma can actually tear that protective membrane and allow the fluid to escape through the nose, the ear, or potentially an open skull wound. Any type of clear, watery drainage following a head injury should increase your index of suspicion, especially when the patient also reports a salty kind of taste in the back of their throat. Okay. So, a CSF leak just simply means that the protective layer around the brain could have been opened and compromised. So, that just increases the chance of infection and then potentially meningitis. So let's kind of talk about the peripheral nervous system, and we're going to have to talk about the 31 pairs of spinal nerves. We're not going to go in depth on cranial nerves or spinal nerves in terms of like what their names are and their functions for the context of this course, but just know the further along you go into your academics and your progression in the medical field, you're going to be exposed to those and probably have to memorize them. But now, if we think about those 31 pairs of spinal nerves, there is a nerve on the left and right at each level of the spine. Okay, and they leave the spinal cord through openings between the vertebrae. Okay, so these nerves connect the spinal cord with the skin, muscles, and the organs. Sensory impulses are going to travel from the body towards the spinal cord, really, while the motor impulses travel from the spinal cord to the muscles. So, because these different nerves serve different areas of the body, the pattern of weakness, altered sensations can really help identify where a neurological pathway has been impacted based on the injury. So once again, the so From this image, you're looking at the peripheral nervous system, and it forms like a branching network that connects the spinal cord with the rest of the body. So near the shoulders, spinal nerve fibers are going to join together, and they're going to create what's called the brachial plexus. And this is what's going to supply the arms and the hands. Okay. Now, lower down, you have the lumbosacral plexus, and that's going to supply the hips, the legs, and the feet. So a plexus itself is an area where these nerve fibers are going to combine. They're going to organize before they continue down into the limbs. Okay. Now, because of this specific arrangement, an injury that's close to the spinal cord that could produce different patterns of weakness, sensory loss from an injury that's farther along a single peripheral nerve. As I talked about, there are 12 cranial nerves. Okay. They connect directly with the brain and carry out very specialized functions that involve the eyes, ears, the face, mouth, and throat. Okay. There are also some that actually regulate certain internal organs. So let's do a quick rundown of what those 12 are. But again, for the context of this course, you don't have to memorize them all. I just really like you to be exposed to them. Okay. So number one, you have the olfactory cranial nerve. So this is for smell. Number two, you have the optic nerve. This is going to be for vision. Three is your oculomotor. So this can be for eye movement, like your eyelid elevation, but also more relevant to be pupil control. Four is going to be your trochlear, which controls one of the muscles that help move your eye. You have the number five is trigeminal. So this can be more for facial sensation, for chewing. Number six, you have your abducens, which is more to move your eyes outwards. Number seven, you have your facial, which is going to be more for facial expressions and a little bit of part of your taste buds as well. Number eight, you have the vestibulocochlear. This can be for hearing and balance. Number nine, you have your glossopharyngeal, which contributes more to swallowing and your gag reflex, and a little bit on your taste side of things too. Number 10, you have your vagus nerve, which is going to control more of a swallowing and voice and carries out an autonomic signals to the heart, lungs, and the digestive system. Number 11, you have your accessory nerve, and this is going to be more for turning your head and shrugging your shoulders. And then 12, you're going to have your hypoglossal, which is for tongue movement. And again, very easy to remember, but also hard at the same time, right? It's just more memorization. A lot of programs are going to have you like, they're going to tell you like the best way to remember it is to come up with like some random phrase. Um, like I'm trying to remember the one that I used. It was uh, okay, it's gonna be dumb. It was the gosh, what was it? It was the taste and feel of very good ham. I gotta get the V in there. The very fine ham, very good, very fine, very. I don't remember, but it was ridiculous. Okay, but find out what works for you, and that's a lot about in the medical field, especially when you're going through the educational part. You need to find memory aids. Okay, so find acronyms, abbreviations, sayings to help you remember all these different things you're expected to remember. It's not everyone can learn just by have that photographic memory and just see a word and you just remember it. So whatever it takes, you just got to find what's right for you. The peripheral nerve system, again, we're going to continue on. We have two types of peripheral nerve fibers. And again, they're going to be grouped into direction and purpose. Okay. So you have sensory fibers, and again, they're going to carry information from receptors in the body towards that central nervous system. Different receptors are going to respond to specific stimuli, pain, touch, pressure, temperature. Okay. Then you have motor fibers. Okay. So these carry instructions from the central nervous system to the muscles, and that's what's going to produce the movement. Okay. Many named peripheral nerves contain both sensory and motor fibers. So any type of damage to one nerve could affect sensation and movement or individual. Okay, so during your neurological assessment, motor function and sensations are checked separately because one pathway could be impaired while the other is actually just fine. Now, connecting nerves are really found within the brain and spinal cord. They are more commonly called interneurons and act as a link between other nerve cells. So, an interneuron may receive a sensory message, pass it towards the brain, connect it with a motor pathway, or just help coordinate several different responses at once. Now, this allows the central nervous system to just organize information before actually producing an action. Some of these connections create very short pathways through that spinal cord. But those pathways are just going to allow that rapid response to a harmful stimuli and it really form the basis of what we're going to call the reflex arc. And we're going to talk about that reflex arc in a second, a little bit more in depth. Okay. Now, how the nervous system actually works, right? So the system controls three broad types of activity. Okay. So we have reflex, voluntary, involuntary. A reflex, again, is a rapid automatic response to a stimulus, like pulling your hand away from like something that was hot. A voluntary activity is an action we consciously choose to do, like walking, talking, and reaching for an object. Then we have an involuntary activity, which really continues without any constant conscious control. This could be your breathing, your heart rate, your digestion. All of that kind of falls in that category. Now, some functions do overlap, right? So breathing usually occurs automatically, although we can actually briefly control the rate or hold our breath or take a deep breath. Okay. But we're going to go ahead and talk about in the next few slides just the how these forms of control are separated and explain how the body actually produces them. So let's talk about the reflex arc first, right? So the reflex arc is kind of pretty cool. Uh, so it's a short, very rapid pathway through the nervous system, and its main purpose is protection. Right. So if the skin detects a harmful stimulus, like that intense heat, like touching a hot stove or just a hot item, a sensory nerve is going to carry that warning into the spinal cord. A connecting nerve cell, then it's going to pass the message to a motor nerve, which activates the muscle and pulls the body away from the danger. Now, because the response begins with the spinal cord, movement can start before the brain actually has fully interpreted that sensation as pain. So, information is still going to travel upwards to the brain. So, we really become aware of what just happened moments after the protective response begins. So, that's why sometimes you might, again, touch something very hot and pull your hand away, but not feel that intense burn at least right away. So here we have a good little diagram. So if you follow the arrows on this one, the pathway again begins when the heat receptors in the hand detect that flame. That sensory nerve is going to carry the message again up the arm into the spinal cord, and then in the spinal cord, that connecting nerve is going to nerve cell transfers the message to that motor nerve. Then the motor nerve signals then the motor signal, sorry, then travels back towards the muscle of the arm, causing the elbow to bend and the hand to move away. But again, at the same time, information is continuing towards the brain where the person becomes consciously aware of the heat and that pain. Okay. But this sequence brings the pathway together. Sensory information travels in, spinal cord organizes and has that rapid response, and then the motor instruction travels back out. Now, the nervous system uses, again, two broad control systems. You have a somatic nervous system and an autonomic nervous system. Now, the somatic nervous system controls the skeletal muscles and activities that we choose to perform, like walking. Okay. Sensory information. From the skin, the muscles, and joints are going to help guide those movements. But again, so it's all voluntary. But again, it does involve both motor and sensory nerves. Then we have the autonomic nervous system, which regulates those internal functions that really continue in the background of our everyday life. That's again digestion, your blood vessel tone, the release of hormones, so your gland activity, things of that nature. But again, these two systems often do work together. An example, like, during exercise, the somatic system moves the arms and the legs, while the autonomic system adjusts the patient's heart rate or the person's heart rate, breathing, circulation to meet the new needs of the body, specifically when we're talking about oxygen and energy. Now, the autonomic nervous system does have two extra branches. So again, this whole topic again could be and is like a whole college level class. So this is more of a basic overview, but it is a lot to take in. So don't stress out if you're not memorizing all of this. Just again, have a basic understanding. Okay. Now, the two branches here are some of the more important ones to know as an EMT is your sympathetic nervous system and your parasympathetic nervous system. Now, your sympathetic nervous system really prepares the body for an immediate action. Okay. This is what we commonly call our fight or flight response. And this is just your body trying to get ready to meet the demands of a stressor that has been introduced into the environment. Okay. In this case, the pupils of the patient will widen, patient's airway opens up more, the heart rate increases, blood pressure increases. Blood is actually directed towards the brain, the heart, the skeletal muscles. Epinephrine or adrenaline, right, supports many of these change. It has a sympathomimetic effect. But again, you're just trying to increase your blood flow to the brain, the heart, the skeletal muscles to either fight off a stressor or run away from a stressor. So it's your survival instinct more or less. But then you have the parasympathetic nervous system on the other side. Okay, now this supports more on the recovery side of things, digestion, energy conservation. It's going to slow the heart down. It's going to increase activity within that digestive system. But in everyday life, these branches are continually adjusting their influence on the body to maintain something called homeostasis, right? So this means just a stable internal balance. Okay. One is going to prepare the body to respond to a challenge, while the other helps it return towards its resting state. So you're constantly battling between the two to have that balance in your life when nothing is going on and you're in like waking hours. But then when you have a stressor, the sympathetic takes over. But when you're going to go to bed or eat and kind of relax, your parasympathetic takes over. So let's look at the skeletal system. Again, we're trying to focus mainly on the head and spine. So the skull here is divided into kind of two groups. You have the cranium and the facial bones. The cranium is going to be formed from several different bones that are fused together to create the protective shell around the brain. Whereas the facial bones provide structure around the eyes, the nose, the mouth, and the jaw. Now, here the labeled facial bones include your nasal bones, which can be at the bridge of your nose, the zygomas, which are going to be your cheekbones, the maxilla, which is the immovable jaw, and then the lower jaw is our mandible, which is the movable jaw. Okay. Now, these structures form just one connected framework. So a strong impact to the face can actually transfer forces towards the cranium. So really, any facial trauma and injury to the brain can occur in a singular traumatic event. Now, the opening at the base of the skull, again, this is where the brainstem continues into the spinal cord, is called the foramen magnum. Okay. We also use specific names to describe, different regions of the cranium. The forehead is the frontal region. The sides of the head near the temples or the temporal regions. The parietal regions cover much of the upper sides of the skull, and then the back of the head is the occiput. These terms just give us precise ways to describe where the patient was struck, where you found tenderness, the palpations, or where an actual wound is located. Moving on, we have the spinal column. Now, this is the body's pretty much the central support structure. It helps carry the weight of the head, the trunk, allows for controlled movement, and just forms a real protective channel around the spinal cord. It contains 33 vertebrae divided into 5 different divisions. From superior to inferior, you have the cervical, thoracic, lumbar, sacral, and coccygeal. The cervical region is going to form the neck. The thoracic region is more of the upper and middle backs. That's connected to the rib cage. The lumbar region forms the lower back, and then and that's a very that portion carries much of the body's weight. You have the sacrum, which is the fused together portion that forms the posterior aspect of the pelvis, and the coccygeal, which is the most inferior portion, which is also commonly called the tailbone. So if we look at this image, we're going to count out the divisions and like kind of how they're separated and how many you have in each. Okay, so from the top going down, we have 7 cervical vertebrae. This is labeled C1 through C7. We have 12 thoracic vertebrae labeled T1 through T12. And again, these are the way you can tell that these are thoracic is that you have a articulation with the ribs. And then you have 5 lumbar vertebrae, which are fused, or not fused together, excuse me, 5 lumbar vertebrae. Those are going to be L1 through L5. And then below those, you have 5 sacral vertebrae, which again are fused together and form the, again, those are the sacral vertebrae that forms the sacrum. And then 4 coccygeal vertebrae, which are also commonly fused together. Now, again, this label just, these the labels here allow us to just identify precise levels of the spine, right? There are certain clinically relevant ones like the C5, T10, L2, because anything below or at those injury sites, you can have like more of a systemic reaction. And we'll talk about that. One way I learned to memorize these, again, this is very early on. So it's 712, 554, right? So you have breakfast at 7, you have lunch at 12, you have dinner at 5, and then 5-4. So moving on, let's talk about the individual vertebrae. Now, each vertebrae has some similar characteristics and some unique characteristics. So we're not going to go crazy into it, but when you take an actual anatomy class, you're going to learn all about it and how to differentiate. But for here, let's kind of talk about the major portions, right? So you have a solid section at the front of the vertebrae. We're going to call that the vertebral body. Okay. Behind it is a bony arch. Now, when the vertebrae are like kind of stacked together, these arches form that spinal canal, which again surrounds and protects the spinal cord. Then you have the spinous processes, which project towards the back, and those are going to be more so what you're going to palpate. Those and then also the transverse processes, which go sideways. So you're going to palpate those areas when you're doing your trauma assessment. And again, those transverse processes extend towards the sides. Then you have different muscles, ligaments that are going to attach these attach to these various projections, if you will, and going to help support the spine movement patterns. You also have spinal nerve roots that leave the cord through openings alongside of the spinal column. Between most of the vertebral bodies you have something called intervertebral discs. Now, these discs are very important for shock absorption, and they do allow for some movement to occur. But again, the ligaments are there to connect bone to bone to keep everything kind of stuck together. Now, together, again, these bones, these discs, ligaments, the muscles, this is really what gives the two properties of stability and flexibility, okay? And again, any injury here could have more so lifelong disability implications, and we'll talk about it. Now a head injury, so go more specific. So a head injury may involve the scalp, the bones of the skull, the brain, or just several of these various structures all at the same time. Now, the seriousness of the injury is really dependent by whether the brain has been affected. So a scalp wound can look very dramatic because it bleeds a lot, but a dangerous kind of brain injury can produce very limited visible damage. Okay. Now, that same mechanism can also injure the cervical spine, the chest, the pelvis, really any other part of the body. So it's very important your assessment needs to be broad. Okay. So even when the injury to the head is like really attracts your attention, we need to actually be able to not get tunnel vision and just focus on that. Okay. We need to separate the entire body, assess the entire body. Okay. So now we can kind of break off in categories the different types of head injuries. Okay, so we can kind of classify them simply as either open or closed injuries, and this is largely determinant on whether or not there is an entrance or from the environment to the actual cranial cavity. So, in a head injury, the brain could be damaged, even though the scalp and the protective layers of the brain are closed. Okay. Now, a skull fracture can still be present, and bleeding or swelling may develop inside the skull. But again, you have very little visible injury. Okay. But now, in a open head injury, it's the complete opposite. Okay. So that means you have the skin, the skull, and potentially the protective coverings have been breached somehow. Okay. Now, these injuries are often caused by a penetrating trauma, and then that brain tissue can actually be exposed. Um, and we'll talk about how to treat it later. But the terms open and closed, again, just describe the structure of the injury rather than its severity. Okay. A closed injury can still be life threatening, while an open injury just adds concerns more along the line of contamination and infection. So falls and motor vehicle crashes. So these are going to be one of the most common mechanism of injuries for a head injury. Both can involve, direct impacts, rapid acceleration, deceleration, sudden changes in direction, and all these transfer forces into the skull and to the brain. Also, assaults, sports injuries that involve, punching, kicking, tackling, any type of blunt objects, collisions, falls onto the hard surface. The type and direction of that force, it just helps us anticipate what we may find during our assessment, what could be injured. A head trauma can also result from child abuse. Okay, so when you're assessing an injured child, the explanation that is given to you by the caregiver should match the child's age and their developmental ability. Okay. An unclear or inconsistent changing account of what happened, that should raise your concern for a possible non-accidental trauma. And then as EMTs, paramedics, pre-hospital providers, you are mandated reporters, and you would report those types of findings. Okay. Uh, as soon as possible. Now, the mechanism itself, again, that establishes just your initial level of suspicion. Okay, the patient's examination and any changes over time then help determine how serious the injury actually is or could be. So here we have some warning signs of a head injury, and we can divide them into several different groups, right? So we have physical findings like bruising, laceration, swelling, a hematoma, maybe a soft or depressed area on the skull. Maybe you have fluid drainage from the nose, ears. So those are all would be more of a physical finding. Okay, changes in brain function may appear as unusual behavior, maybe repeated questions, memory loss, seizures, issues with their visuals, nausea, vomiting. The pupils themselves actually become unequal or don't respond that well to light. Okay. You could have motor and sensory changes like weakness, loss of movement, numbness, tingling. In more advanced kind of neurological deterioration, you can actually have abnormal flexion and extension of the limbs. And that's what we call, again, posturing, which we'll talk a little bit more later. Typically, we have decorticate or deceperate posturing. You have breathing and circulation changes, irregular respirations, slowing heart rate, widening pulse pressures. Those are all like specific concerning issues that could occur due to a head trauma. But really, following a head trauma, just one significant neurological chain is enough to really indicate that there's a serious injury beneath the surface of the patient of the skin. Scalp wounds. So now, any any injury to the scalp can cause excessive bleeding. Okay, there's a the head and the face have a very rich or extensive blood supply. So even like a little tiny laceration could produce a surprising amount of blood. So it's very important to not get distracted by that. Um, it could become dangerous, but again, you're more concerned about the underlying issues, right? The structures underneath the skin, specifically with the brain and the spinal cord. Okay. Um, Now, when we're talking about children and infants, who have less like total blood volume, those are the individuals where that amount of blood could be more significant in terms of the potential of patient deteriorating much more quickly. Okay. Now, if a patient has multiple injuries to the scalp and facial bleeding, that can also add to more blood loss, and then eventually lead to hypovolemia. Um, Now, a scalp laceration usually does mean that, again, there was a force that was applied to the head. Okay. So now, once bleeding has been identified, assessed, treated, you do have to take careful consideration of the injuries beneath, look for any type of fractures, and how is the patient actually presenting to indicate, hey, is there a potential brain bleed of some sort? Let's talk about skull fractures. Now, a fracture itself is a break in the continuity of a bone. So when we're talking about a skull fracture, we're talking a break in again one or more of the bones of the skull and face. But here we're talking about skull. Okay, so again, we have the frontal, parietal, occiput, and temporal. Now, significant force is required, to break a bone. Okay. And that is the very, very same in a skull. But now that amount of force should raise a concern, again, if you have suspicion of a fracture, that there are structures underneath that could be impacted, like the blood vessels, the meninges, and the brain itself. A skull fracture could be closed with, again, no scalp wound, or it could be open with a laceration, and again, that laceration creates an opening from the environment deep down into the actual skull and brain. The most common way that actually occurs is usually bullets, so like gunshot wounds or any type of like impaled objects. Those are going to be the ones that create that open fracture. Now, many of your skull fractures can't be confirmed just through physical examinations. And nor should it, because again, as pre-hospital providers, you do not diagnose. You can have clinical diagnosis, index of suspicions, have running theories and ideas of what the condition is, but we can't diagnose, even though we might see an actual visible broken bone. But it's really at the hospital with X-rays or a CT scan in this case, where you're going to get the actual diagnosis. But again, in the field, your suspicion should be largely based on the mechanism, what you can see with your eyes, such as, is there abnormal deformity to the skull? What's the neurological findings of the patient, and so on. Now, there are various findings that should raise suspicion for a skull fracture, right? So you have abnormal kind of shape, if you will, contour, if you will, of the skull. You can have a depressed area, or maybe you can actually see the scalp, the actual crack in the skull through the scalp wound. That's all direct evidence that the bone has been damaged. Okay, but bruising can also appear. In two characteristic locations. Okay, so that's more so if it's a closed fracture, but also in an open. But if you see these two signs, it's a good indication that there's some type of skull fracture. Okay, so and these two signs are going to be raccoon eyes and battle sign. So now raccoon eyes refers to bruising around the eyes, while battle sign refers to bruising behind the ear near the mastoid process. So the mastoid process is kind of that lower prominence bone. If we actually have a skull right now, it could be right there, but you see bruising right there. Does not mean that actual fracture occurred there, or an injury occurred there. It's just where there's a fracture somewhere in the skull and it's actually pooling in that area. Same thing with the raccoon eyes. It doesn't necessarily mean that a person was like had a direct force to the front of the face. It just means that there is a potential skull fracture somewhere and you have fluid draining underneath the skin to those areas. So the patient looks like they have two big black eyes. So that just indicates that there is a potential, highly likely skull fracture. Yeah, perfect. So as I just discussed, so that first image on your left, my right, your left, who knows? Uh, that is raccoon eyes. Okay, so you can see the bruising, the ecchymosis, that discoloration behind between both eyes. Now this pattern again develops when the eyes again they're not struck directly, but you have a drainage. Okay, and then the second one you have that bruising behind the ear. Okay, this one's a little bit harder to see, so you have to when you're doing your head assessment during your head to toe, you need to be deliberate with checking that area because again, that is one of the specific traumas you should look for in the head region. Now, both again of these findings do take several hours to appear, and in some patients they can actually be delayed even further, up to 24 hours. Okay, but again, always look and assess and see what you see, document. In terms of treatment, you're thinking possible spinal immobilization because, again, if you have that much force applied to the head and face to cause a skull fracture, you need to do C spine immobilization and then treat for ABCs or XABCs, depending on the situation. To move on, let's talk about linear skull fractures. So this is when there's and it's you can see by the image. This is a essentially a narrow type crack in the skull without inward like displacement of the skull. Okay, so this is what we would kind of consider a non-displaced fracture, and it's really one of the more common skull fracture patterns. Okay, there's no real visible deformity, but it might be impossible to actually feel any type of abnormality during your examination, except for maybe pain. The scalp and skull can appear normal again while that fracture line is, underneath. But it does take hospital imaging to actually confirm the injury. So the outcome really depends largely on whether the brain, any type of blood vessels, or the scalp was actually damaged for you to actually have a suspicion. Now, the suspicion should arise if the patient has a mechanism that is associated with trauma to the head. But again, you might not know that if the patient's unconscious. So make sure you're very thorough with your assessment and your palpations. Now we have a depressed skull fracture. So this occurs when one of the skull, where the fracture is actually driven inwards towards the brain. Now it usually follows like a high, like concentrated, high energy blow from a blunt object. The frontal and parietal bones are particularly vulnerable because portions of these bones are kind of relatively thin, but when they break inward, those bone fragments can actually tear the meninges and damage blood vessels or just injure the brain directly. Because again, you have the bone fragments going inwards. Okay, the patient could have visible depression, abnormal skull shape. But swelling could be difficult to see because of the patient's hair. Okay, so again, be deliberate with your palpations. Just don't go through the motions. Be precise with what you're trying to touch. Okay. And unfortunately, you might just have to kind of more rely on the patient's condition. So, are they altered? Do they have any type of neurological changes to suggest that there is something going on with the brain after a mechanism of injury suggests there was trauma to the head? Now, a basilar skull fracture. Now, this involves the floor of the skull, or the base. Okay, so it's really associated with another high energy trauma, like a big fall or a car crash, and it often develops when there's a linear fracture that extends more downwards towards the base of the skull. Now, because the fracture is pretty deep, it usually can't be seen, can't be felt. So the clues are going to come from the blood or the fluid that's moving away from the injury. So again, this is where your raccoon eyes come into play, your battle sign, or when you have that pink kind of clear cerebral spinal fluid that's draining from the nose and the ear. So again, that cerebral spinal fluid leak just means that the protective membranes have been breached, disrupted, and that's creating a very big risk for bacterial meningitis. Okay. Um, Now, like we talked about, the bruising can be delayed, so the patient could look perfectly normal. So, but again, you shouldn't just rule out a basilar skull fracture because in the absence of bruising. We're going to talk. I want to say we're going to talk a little bit later about the halo test, which is how you could assess for that drainage in the nose and ears, because sometimes it could be hard to see that fluid coming out. Um, but if you do see something, you'll take a little 4x4 gauze, place it on the area covering the nose or the ears, wherever that blood or that drainage is. Even if you just see blood, you still want to try to do the halo test, because when you pull out that gauze, you're going to see either kind of a yellowish, goldish tinge color circle, if there's just cerebral spinal fluid, or you'll see a red dot. You can't see me, I'm just using my hand. You'll see like a red dot surrounded by that gold yellowish tinge circle, and that's what that halo, like an angel halo, is referencing. But that's the indication of a basilar skull fracture. Um, So go deeper into our open skull fractures. Again, this is when the skull itself has been breached. So there is a pathway into the cranial cavity. Now, these usually are also a blunt or penetrating trauma. And again, the issue is that you're exposing the meninges, exposing brain tissue. So not only is that bad for the brain itself, and then you have that contamination, that infection type situation. But once it's open, it's just a bad idea. So the force involved here, though, is likely to have damaged blood vessels, damaged brain tissues. Uh, Usually, it's so much force that it's just one system that was involved. So it's going to be like multi-system type of trauma. Um, but try your best, and this is going to be true with any injury, try your best not to get distracted. um, and when I say distracted, you don't want a trauma type injury that you're seeing to turn your attention away from your foundation. And your foundation is always the airway, the breathing, the circulation. Okay. You don't want to jump in on scene. You see a person's leg that's like twisted the wrong way and just immediately start treating that because, oh, that looks gruesome. That looks horrifying. You still need to start with your primary, again, seeing safety, BSI, but go back, make sure the patient has an open airway, make sure they're breathing, make sure they have a pulse before you start worrying about the patient's limbs and their injuries, right? Because, yeah, they have a broken leg, but if they're not breathing, they're not going to make it, right? So they can be without, their leg being fixed for a second while you make sure they have an open and maintained airway, make sure they're breathing adequately, make sure they're perfusing adequately. So again, never let any trauma take away from that, unless of course it's a severe bleed, and then it becomes XCAVs, XAVCs. That's a whole other thing. But I digress. A TBI. So if you're a sports fan, football fan, you've heard the term a traumatic brain injury quite often. So let's kind of discuss what actually that is. So a TBI is actual physical damage that is caused to the brain from an outside force. So that could be a direct force, it could be a rapid acceleration, deceleration, a crazy rotation of the head, or penetrating trauma. Now, the effects of it depend largely on the location and the severity of the injury. A TBI may interfere with thinking processes, memory, movement, speech, behavior, emotional control. Now, the term does cover a wide range of injuries. A concussion, right, is classified as mild TBI, while these moderate and severe injuries may involve prolonged unconsciousness, seizures, major neurological deficits, impaired breathing. But so it's just a whole lot. Okay. Um, yeah. Yeah. And TBIs can also be classified into kind of two broad categories, which we're going to talk about. You have your primary, which is going to be your direct injury, and then your secondary, which is going to be your indirect, which we'll talk about. Um, so your primary brain injury, so this happens the moment the force actually reaches the brain. Okay. So tissues may be bruised, they can tear, they can just be penetrated, blood vessels can rupture, nerve fibers can be stretched, can be sheared, but it's actual physical damage. Okay. Whereas a secondary brain injury, that's going to develop afterwards, and that can continue for minutes, days, hours. Okay. Now the causes are going to be, cerebral edema, intracranial hemorrhaging, increases in pressures, reduced blood flow, and infection. Okay. But really, the two most common contributors here are going to be hypoxia. Again, that's low oxygen levels, hypotension, which is your low blood pressure. Both really reduce the supply of oxygenated blood that's available to reach the injured brain tissue. Now, in terms of your treatment, there's not much you can do for a primary brain injury because by the time you get there, the injury has happened, right? The damage has been done. Um, the way you protect from the primary injury is about prevention, right? It's about having proper technique for football tackling. It's about having the appropriate equipment to protect yourself, things of that nature, right? So as an EMT, you're going to be focused more on assisting with reducing secondary damage. Okay, that's secondary injury. That means you're protecting ABCs, you're oxygenating, you're ventilating, and then you're transporting to definitive care. So brain injury again can be a result of blunt trauma, can be a result of penetrating trauma, could be a result of that rapid movement of acceleration, deceleration. We talked about this in a previous chapter, but we have a very common acceleration, deceleration injury pattern, and we call that coup counter coup injury. Okay. Now, the coup injury portion occurs when that brain first strikes inside of the skull. Okay. Now, the skull or the brain itself is not like necessarily anchored in a fixated position inside the skull. It does have the ability to kind of be moved around and bounce around if enough force is applied in terms of, in this case, the acceleration and deceleration. So as that head changes direction really rapidly, the brain has the potential to move across the cranial cavity and strike the head, and at the same time can actually bounce back and have a shearing force pulling the brain, causing a counter coup injury. Okay, so if you think about like a frontal car crash, right? The front of the brain is going to be compressed while the tissue in the back is stretched, right? So your brain is getting, because it's a rapid deceleration from the frontal crash. So your body stops, but your brain keeps moving forward and it's pushing against the skull. Okay, but now at the same time, back here, it's still tethered to the back of the skull, but now it's getting pushed this way, so it's actually tearing over here, but it's getting compressed over here. So that's where you have a coup counter coup injury, where you're having injuries to both the anterior and posterior sides of the brain. Okay, it's a bad time. Now, following a brain injury, your tissue will probably start to swell. Okay, so this is what we're going to call cerebral edema in terms of swelling of the brain, and this again could take several hours to be clinically obvious. So by the time you get the patient, it's probably hasn't occurred yet, but it's always something to understand of a potential of happening. So you might do certain interventions and treatment in in case that situation happens. So it's like kind of like preventative or prophylactic, if you will. Low oxygen levels in this case could make the swelling and that cellular damage even worse. Okay, so this could explain why a patient could appear, stable soon after an injury occurs, but then start to develop a headache that's getting worse, vomiting, start getting confused, start becoming altered entirely. Okay. This is also where seizures can actually occur after a brain injury because of the swelling, where now the electrical activity in the brain becomes unstable. And this seizure can actually interfere with the patient's airway, their breathing, while also increasing the brain's demand of oxygen. Okay. So swelling in this case does become dangerous because again, the adult skull, it's the adult's brain inside the skull, it can't or hold on. The skull can expand. So the brain, if it starts to swell, it starts to get bigger, it's condensed inside of that skull. So that's where you're going to start having increased intracranial pressure and then leading to a possible brain herniation, which we'll discuss what that is. Ah, so like we said, you have the skull. You can kind of think of it as a container that cannot be moved, right? The container that cannot expand, right? And it's holding all your brain tissue, right? It's holding all your brain tissue. It's holding your blood, and it's holding your cerebral spinal fluid. So when bleeding starts adding more volume, or when that tissue starts to swell, the skull itself cannot expand to make room and accommodate that extra stuff. Okay. So that pressure inside the cranial cavity is going to start to rise. And that's what we call an increase in intracranial pressure or an increase in ICP. So as that pressure starts to increase, the brain tissues, the blood vessels that are the blood vessels supplying it actually become compressed as well. So this is going to reduce the amount of oxygenated blood reaching the brain and can actually worsen that existing injury already. So if the pressure becomes severe enough, the brain tissue can actually be forced downwards towards that foramen magnum. Okay, so this is what we're going to call that herniation. Okay, and then as we remember, what's in that base of the skull near the foramen magnum is your brainstem. Okay, so if that herniation is occurring, you have pressure going to that foramen magnum. That means it's going towards that brainstem, and it starts to compress that brainstem. This is where your consciousness, your breathing, your heart rate, your blood pressure control. This is where that becomes at risk because now your brainstem is in trouble, essentially. So again, that rising intracranial pressure that kind of tends to increase as again the condition becomes more severe. Early findings of increased ICP, you're going to have your worsening headaches, nausea, vomiting, confusion. Potentially more patient becomes more drowsy. The patient's pupils can start to react a little bit more slowly. They might start becoming unequal in terms of the pupil size. You might see certain breathing pattern changes, like Cheyenne-Stokes or Chain-Stokes, depends on how you like to say it. Cheyenne-Stokes or Chain-Stokes. So this is an actual specific breathing pattern that is specific to a head injury. Okay, this is where your ventilations are going to alternate between very deep and then very shallow, and then there's going to be periods of apnea. So typically, how it goes is you kind of see very little chest rise and fall, then it gets really big chest rise and fall, and then it starts going very little again. So that shallow, deep, shallow, and then you might see no breathing for a little bit, and then it starts going shallow again, and then very deep again. So that is all because there's increased intracranial pressure and you have that herniation occurring on the brainstem, okay, and specifically in the base of the skull. Now severe neurological dysfunction can cause decorticate and decelerate posturing. Okay, the blood pressure may rise while the pulse slows. The gap between the systolic and diastolic pressure are going to widen. And these are all clinically relevant for increased increased ICP. But a a pairing or not sorry, a pairing, a grouping of symptoms can actually tell you, hey, there's a likelihood of ICP. We call that Cushing's triad. So that's when you have an increasing systolic pressure, a decreasing heart rate, and irregular respirations. That's together kind of tells you, hey, this is Cushing's triad, and this could be a late sign and a significant sign that again there is a possible brain herniation occurring. So let's talk about the different type of hematomas. And again, this all plays a role into intracranial pressure because again, you have an increase of bleeding occurring inside of the brain. So let's start with an epidural hematoma. Okay, so an epidural hematoma really is a collection of blood between the skull and the dura mater. Okay, so this really commonly follows a direct impact to the temporal region that fractures again that thin bone and it tears the middle meningeal artery. Okay, now because the bleeding is usually arterial, the hematoma is going to expand very quick because again there's a lot of pressure, a lot of blood flow in those arteries. So the patient could lose consciousness right at the time of injury. They could wake up and really appear normal or improved temporarily, but then they're going to quickly deteriorate again as that pressure is going to that continues to rise inside the head. Now, what we call that temporary improvement is called the lucid interval. Okay, not present in every single case, but again, that's where you might arrive on scene and the patient's conscious, and then a bystander says, or they say, like, "Oh, I got hit in the head and I passed out, and then I woke up and I start feeling good." So again, the mechanism would be a direct impact to the temporal region of the head. They go unconscious, they start, and then they come back out of it, but then they're going to start deteriorating once again. Okay. But other again symptoms, signs you might see that worsening headache, again falling level of consciousness, maybe dilated pupils, fixed pupils potentially on that same side where the bleeding is. Those would be all like findings that are concerning to you. Okay. But again, the anatomical feature that you gotta remember is that the blood here lies outside of the dura, but inside of the skull. Okay. Uh, as this progresses, you are going to need surgical intervention to essentially what we call like evacuate that blood to relieve the pressure, which I'm sure you've probably seen in the movies, kind of like drilling into the skull to release the blood out of it. Because again, it's between the skull and that top layer of the meninges, so you're not actually going into the brain. Next, we have a subdural hematoma. Okay, so now this forms between the dura mater and the arachnoid mater. Okay, so it usually results when there's a rapid movement of the brain that stretches and tears the bridging veins that are crossing inside this space. How this occurs is typically from like the mechanisms are from falls and deceleration forces. Um, and again, a deceleration force would be like an abrupt stop or during like a car crash, and then or a fall. You're falling at a terminal speed, and then bam, you stop when you hit the ground. Now, because the bleed here is typically a venous bleed, symptoms are going to be a little more gradual than they were for the epidural hematoma, which was more of an arterial bleed. So the patient may experience like a headache, maybe some slurred speech, be confused, again, have that drowsiness kind of start happening. And then their consciousness is going to start to decrease over time. Now, older adults, like the elderly, your geriatric patients, they're a little bit higher at risk for this because you have what's called age-related shrinkage of the brain. And this is going to actually place more tension on those bridging veins and create additional room for blood to collect before those symptoms become obvious. Also, in this group, they have a higher likelihood of having anticoagulation medication, and that could also increase the amount of bleeding from a smaller bleed inside the brain, because again, that means that their platelets are not functioning as they should, or it, by design in this case, and that means bleeding is going to continue and not stop. Okay. But again, for a subdural hematoma, the symptoms could appear hours, days, weeks after the original injury. So, a recent fall remains a relevant type situation, even when the patient initially seemed well. So again, be a little bit of a detective. You might have a patient call like 911 because of that worsening headache, or they start feeling like out of sorts. You're going through your AEIOU tips, trying to why is this patient altered? One of the ones again is trauma. So again, ask if there's been a recent trauma, not just so much that they were involved in a trauma before you got there, but a recent fall, like, oh yeah, they fell and went to the doctors like a week ago or a couple days ago. That should start kind of pointing you in a direction. Hey, maybe there's a brain bleed. So again, uh, being a good EMT is about gathering information, okay? Not just doing the bare minimum, okay? Taking in all of the information. Because again, intervention wise, treatment wise, there's not a whole lot that we're able to do. So the best thing you can do is be an advocate for the patient, learn all of this, and then apply it in the field, even though it could be very unlikely that this patient's altered because of a fall that happened a week ago. But you never know. You never know, and you won't know unless you actually study and learn this type of life information and have that in your tool belt, so to speak, to ask those pertinent questions when you're on scene. Moving on, we have the subarachnoid hemorrhage. Okay, so this occurs in the space between the arachnoid and the pia mater. And again, this is where that cerebral spinal fluid circulates around the brain. Uh, the bleeding here is usually a result of a trauma, but can also be the result of a rupture of an aneurysm. Okay, and as we learned earlier, in the medical side of things, an aneurysm is a weakening of a blood vessel wall. Okay, and typically it is an artery that we're talking about because those are under the most pressure. But that aneurysm area can rupture and then cause a bleed. Now, when it's in the brain, we will typically call that a hemorrhagic stroke. Okay, uh, but in this situation, it's not in the brain, right? So we're not talking about a cerebral artery. We're just talking about the subarachnoid space. Okay. Now, the clinical classic presentations, if you will, uh, of this area. Sorry, just double checking I was recording. Is a sudden extreme headache that really is going to be very rapid onset and quick to the max severity. Okay. Your blood is mixing with your cerebral spinal fluid, and that's what irritates the meninges. And that could cause a stiff neck, neck pain, nausea, vomiting, dizziness, a sensitivity to light. Okay. Now, as that hemorrhage becomes more severe, intracranial pressure is going to rise, and the patient again could develop confusion, have issues with their pupil sizes, have seizures, maybe lose consciousness. Okay. Now, this is I'm selling this part because again, trauma does not have to be present for this situation. So, an abrupt severe headache with neurological deterioration again should also be treated as a serious emergency. And one of your big clinical diagnoses here should be a potential a stroke because those are very stroke-like symptoms that we were discussing. Now we're going to talk about an intracerebral hematoma. Okay, so now this is actual bleeding inside of the brain tissue itself. Okay, penetrating trauma again is going to be one of the more common causes, but again, a severe blunt trauma could damage vessels inside the brain. The exact effects of this just depends really on the size and the location of that hemorrhage, and also if there's any other type of brain injuries that are present based on that impact. But blood directly damages uh, blood can directly damage nearby tissue by adding swelling and increasing that intracranial pressure. So it can essentially strangle the cells in the surrounding tissues. Once symptoms become more obvious, that's when the patient can deteriorate rapidly. So these injuries can have a very high mortality rate, and surgery can be very difficult when the bleeding is so deep inside the brain tissue and so close to those vital structures. So it's very unfortunate, but and the worst thing, there's not much you can do for it in the field again. So the only thing you can really do is again, uh, minimize your scene time, spinal motion restrictions, monitor ABC, CABs, transport to the appropriate facility. Concussions. So a concussion is classified again as a mild traumatic brain injury. Okay, typically will follow a blow to the head, but again, it can also be caused by that sudden movement that just causes the brain to shift inside the skull. A concussion is just a temporary disruption in how the brain actually functions. Okay, so the patient can be dazed, confused, kind of slow to respond. Um, there's like a really a laundry list of issues that could arise from a concussion. You could have sensitivity to light, nausea, vomiting, tinnitus, so it's ringing of the ears. So the brain, again, the brain can act in all sorts of ways. So in this situation, there's no real structural damage. Okay. But again, you're going to have a function issue. Okay. So even if you have like a CT scan, you might not see any actual damage to brain tissue. Okay. Um, yeah, so more than actually 90% of patients don't experience a loss of consciousness for a concussion. So don't rule out a concussion, just a potential concussion, just because they didn't lose a consciousness. But again, you can't also rule out other type of brain injuries. Yeah, there's so many avenues you can go, but again, concussion is just one of the pathologies that it could be due to a direct blow to the head, or again, rapid movement of the head, which is shaking the brain. Um, oh yeah, I don't know how I forgot this one. Yeah, so memory loss is another common symptom of a concussion, especially more severe concussions. And when you have memory loss, we call that amnesia. Okay, but the timing of the missing memories actually helps describe the problem a little bit more, and we have specific words or terms for that type of amnesia. So you have what's called retrograde amnesia. Now, this affects the events that happen before an injury. Okay, so the patient may remember earlier parts of the day, but have no memory of the actual collision, or maybe the moments like leading up to it. Okay, then you have anterograde um, um, amnesia, and that affects the ability to form memories after an injury. So the patient may repeatedly ask what happened because each answer is forgotten within a few minutes. Okay, now again, this goes away, this amnesia typically, but you'll just expect to have them do those repeated questions. So when you have these patients, you need to ask for the last event that the patient actually remembers before the injury, and also the first event that they remember afterwards. Okay, you might need to utilize witnesses in the area to help identify those memory gaps, because again, the patient might not be able to, you know, recognize that they forgot anything. So again, those concussion symptoms I was talking about, they do affect physical function, thinking, behavior. So really ask about dizziness, nausea, their cognitive functioning. Ask about behavior. Is there any sort of speech? Some patients kind of feel groggy. They kind of feel like they've slowed down, like they're going in slow motion. They have a trouble like walking. But again, these symptoms can fade before you actually even get there. So ask the patient what they experienced immediately after the injury and how they feel now. Okay. Uh, a concussion is diagnosed from the history and the clinical findings, right? So CT imaging is used to look for structural injuries like bleeding and swelling. Um, But for a true concussion, there is none, but we can't rule it out, right? So anyone with a suspected concussion, they still need that medical evaluation, even if they feel fine at that moment when you first get there. And especially for athletes, they should be removed from play, formally assessed, and then have to go through a process of being cleared for return to play, especially if they were diagnosed with a concussion. Now, moving on to a brain contusion. So the this is just a bruise within the actual brain tissue, right? So it's usually caused by a blunt trauma. This is where the small blood vessels are damaged, and this allows for blood and fluid to collect within that injured area. Um, this is where a concussion mainly causes that temporary a change in function. This contusion produces actual structural damage to the brain, and this can be visible on hospital imaging. The bleeding and swelling that is associated with a contusion can increase the intracranial pressure and cause a lot of the warning signs that are associated with that severe brain injury, like confusion, reduced consciousness, seizures, weaknesses, pupillary changes. Now, because the brain tissue has been physically injured, the effects of this could actually be a lot longer lasting and potentially permanent. Now, other types of brain injuries, this could also be more of a medical problem rather than an actual trauma. So, a blood clot, for example, could block circulation to the brain. A weakened blood vessel could rupture, causing bleeding. High blood pressure and just other diseases affecting blood vessels can increase the risk of a spontaneous hemorrhage. So the resulting, signs of this could look very similar to a TBI. So the patient again could develop confusion, slurred speech, unequal pupils, vomiting, altered level of consciousness. But the sequencing of events, this is what matters, right? So a stroke or a seizure may cause the patient to collapse and strike their head, right? This leaves both a medical emergency and a traumatic injury. So a witness should be able to help, or hopefully can help, clarify whether the neurological change began before or after the fall. But it's just an important kind of note as an EMT, as a medical provider, to always think of a big picture. Always think of various clinical diagnoses, have different differential diagnosis. Don't get just focused onto one element. Now, again, is it really going to change your sequencing of treatment? It could. Now, when it's for sure an injury, that's what it is. Whether it's a different type of TBI, it's not going to really have that big of a difference on what you're going to do. But differentiating a trauma versus a medical situation, that could pay dividends on what the issue is. So just because it looks like a traumatic situation doesn't mean that is what it initially was. So still do your due diligence to assess, go through all your AEIU tips, get a comprehensive assessment of that patient to figure out really what did happen. So moving on to spinal injuries. The spine itself can be injured in various ways. It could be injured by compressing it, bending it, twisting it, pulling it apart. Okay. An axial load here will send, this is more the compression aspect where a force can be applied directly on the patient. Um, and cause essentially forces to be transferred all along the spine. An example of this could be a head first dive into a shallow swimming pool, and where their head smashes onto the bottom of the pool. The axial load, the compressive forces, are going to travel along the entire spinal column, and that could cause intervertebral disc issues. It could cause fractures, a whole lot of things. But it doesn't always have to go from the head. It could also go from the feet, right? So if you jump off a building and land on your feet, the forces will transfer up the spine. Okay, so Again, this could crush a vertebrae. It could cause a vertebral disc to herniate. Um, it could even lodge a bone fragment into the spinal canal. You can also have a hyperflexion type bend to the spine, either too forward or hyperextension forces too back. That could cause issues. Hyperrotation, where you're twisting or lateral bending too much, or a distraction injury. So all of these different forces could be an underlying issue to cause an injury to that spine. Um, Again, as I talked about, these forces could cause fractures. There also could be ligament damage, strains, sprains, damage to the spinal cord itself or the nerve roots. Your patient may report like a midline neck or back pain, tenderness, numbness, tingling, weakness. A displaced vertebrae may occasionally create like a palpable change in the alignment. We call that a step off. Um, so as you're palpating the spine, you might notice like a nice bulge or bump. Any type of neurological loss could affect one limb, one side of the body, or maybe everything below a certain injury area. A severe fracture can also be present while the movement and sensation is actually the same, particularly when the cord hasn't been damaged or the patient is distracted by like another type of injury. But for suspected a blunt trauma to the spine, you still want to use spinal motion restriction, so SMR. And again, follow your local protocol on this one because it is changing across the country. But SMR again combines again specific, purposeful positioning of the patient, coordinated movement, manual inline stabilization, appropriate equipment, all with the goal of um, ensuring or doing your best to reduce the likelihood of manipulating the head or spine, aggravating the injury even further. Now, your patient assessment during your scene size up, this is really where you could gather a lot of pertinent information on how that person was injured. So this really starts at the mechanism, and it should immediately raise concerns for a possible head or spine injury. These include, car crashes, motorcycle crashes, auto versus pedestrians, rapid deceleration, blunt trauma, penetrating trauma. Really anything that puts undue forces and load on the head or the spine. Now, we're gonna the textbook itself identifies certain significant MOIs. Uh, for this one, it's going to be falls greater than 10 feet. Um, there are so many different ones, but again, understand your local protocol, especially when they're talking about your trauma assessment or activation of or trauma activation. So I don't want to confuse you. But your evidence on scene can really help you understand how much energy was transferred to the patient. Okay. For example, if we look at the picture here, we have a starred windshield, right? So a starred windshield suggests something struck it. So in terms of on the inner side of things, this is a possibility where the head of a patient struck the windshield, causing that crack. Okay, and that takes a significant amount of force for that to occur. If you look at someone's helmet, right? So if it's dented, if it's scraped, you can assume that forces were applied to that area. So again, these are just clues that tell you, hey, forces were applied here. There could be an associated injury to that area. Okay. Um, but really the MOI should only kind of guide your suspicion. It's really the examination that determines everything else. Okay, so don't let just the mechanism dictate how you're gonna do everything. It's just one piece of the puzzle. As always, patient care again starts with scene safety. For head and spinal injuries, they often occur in environments that can also injure yourself, bystanders. When we're talking about car crashes, you got to think about oncoming traffic, unstable vehicles, broken glass, possible leaking fuel, electrical systems, undeployed airbags. Other scenes could involve violence, unsafe kind of water conditions, unstable structures, various sporting equipment. So you really need to use the appropriate, standard precautions in all of these situations before you actually approach. Okay, because again, care often takes place close to the patient's airway, and again, it could involve blood, vomit. So gloves, eye protection, a mask, all are going to be sensible minimum levels of protection you should think about. Um, Before just going onto that patient. Also, during this time, you should think about additional resources to help mitigate the situation. Do you need additional? Do you need advanced life support if the mechanism of injury looks significant? If there's a lot of patients, if you need to control the vehicle or stabilize or extricate the patient, maybe you need fire department, maybe you need law enforcement to control traffic. Um, so yeah, anything that you might need during this situation, you're just again evaluating your scene, gathering information, and then making decisions based on that information that was gathered. Like I talked about, when you do your scene size up, you want to do a 360 of your environment. You want to, if it's a car crash, you want to walk around the vehicle. You're assessing for any type of damage to the vehicles. You're looking for intrusion. You're looking for what type of collision it was. Um, and again, this is all to determine what forces could have been applied to that patient. So you have some form of idea to going in on what injuries you should suspect to see, and then that will tell you like do you see an injury that you didn't suspect to see. So it's just all plays a role in how you're going to approach the situation, but again, it's just one element of it. um your primary assessment, the whole purpose of the primary assessment, again, is to rapidly assess, treat those life threats, find anything that's critical, gather a foundation, a baseline of the patient, and then make your treatment decision. Okay. Now, in this situation of traumas, you always want to be looking for those life threats. Now, you should start with your acronym XABCs. That sequence should guide your care for all traumas. That X, again, and it does go in an order, specific order. The X represents exsanguating bleeding. Okay, so that just means you need to control bleeding. And when we say control bleeding, we're talking about like those severe bleeds, bright red blood spurting out, copious amounts of dark red blood oozing out, and just a huge puddle of blood on the floor, where you should really forego the rest of your assessment at the moment, stop that, and then go back to the traditional airway breathing and circulation. After you're done with your XABCs, or during, it kind of depends on the amount of resources you have on scene. This is where you need to ask yourself, do I need to hold C-spine precaution? Is this a benefit for the patient? So, um, to do that, you're going to kind of think about, all right, how should I handle the patient? You're going to assess the patient in the position that they were found. And again, when it allows for it, you would hold C-spine precautions right away. But if you have limited resources, you want to make sure the patient has an open airway, they're breathing, they have a pulse, prior to making that um, asserted effort to maintain immobilization. So it should be now the reason to do SMR should be based on the patient's mechanisms or the injury mechanism, the patient's level of consciousness, the chief complaint, uh, but combined, okay, all together. So when you are concerned, one provider should be manually supporting the head and the neck, while the other is continuing on with the assessment. Once it's applicable, you're going to go ahead and apply a cervical collar. And then again, once it's applicable after that, you're going to go ahead and do a log roll, assess, put the patient on a backboard, move the patient. Again, the whole purpose of SMR is to secure the patient so you do not mistakenly, accidentally manipulate the head and neck and spine in a way that causes further injury. Okay, we're just trying to reduce the likelihood of that from occurring. Um, Now for blunt trauma, factors that would support spinal motion restriction kind of fall into two categories, evidence of injury and an unreliable examination. So, evidence of an injury, that's going to include, The midline neck, back pain, tenderness, numbness, weakness. Is there any visible deformity to the spine? Your examination may be unreliable when a patient's Glasgow Coma scale is below 15. Okay, so that just means the patient is unable to give you appropriate answers or any answers at all. And again, the reason why that could be is a multitude. So we don't need to get into that. But yeah, but there could be the patient is under the influence of alcohol or drugs. They could have another serious injury that's kind of like making them not tell you that they have head or neck pain because their leg really hurts. So it's just pain that can mask other pain, right? There could be communication barriers, developmental issues. Patient could just be in a lot of emotional distress. So when the findings are present, though, or you just can't trust your examination that they're to rule it out, then use SMR according to your local protocol because it's always better to err on the side of caution. Now, head and spinal injuries again frequently do occur together. Because the same force can affect both the brain and the cervical spine. Now, in a responsive patient, speech and memory, those are going to be very important clues. Confusion, slurred speech, repeated questions, inability to remember events. Again, those could indicate a form of TBI. Those repetitive questions, often means the patient's struggling to form new memories. So now you're thinking more of a concussion. Um, Behavioral changes, agitation, combativeness, an unusual emotional response, those are all pertinent neurological findings and aren't necessarily just because the patient's not cooperating. Okay. But again, other issues are something that you have to think about as well. Hypoglycemia, stroke, intoxication, those can all produce similar signs of a head injury. So, in the setting of a trauma, manage the patient as having a possible TBI, but again, you still need to assess for the other potential underlying causes. So continue checking the neck for or back for pain, weakness, numbness, unequal movement between the two sides of the body. So just do a thorough trauma assessment, but also don't neglect your medical assessment as a potential underlying cause. Um, yes. Okay. So AVPU is just it's an easy and quick way to frame the patient's level of consciousness. Okay. So if we break it down, is the patient alert and awake? So typically to me, that's more you arrive on scene, they're looking at you, they're just like well, they're right there with you. And that's usually what happens. You arrive in someone's bubble or arrive on scene. Most people are going to look at you. So that tells me that they're alert. Okay. Now, if they're not doing that, their eyes are shut, they're looking somewhere else. I need to do a verbal stimuli, like, "Hey, sir, how you doing? Miss, can you hear me?" And if they respond to me that way, after I say that, then they're a V. So that means they respond to verbal stimuli. If they didn't respond to that verbal stimuli, I would go in for a painful stimuli, a noxious stimuli. Typically, you can do a trapezius pinch, and again, depending on your protocol of what type of painful stimuli you can do. If they respond to that, okay, cool. They're a P on the painful stimuli or on the APU scaling. But if they didn't respond to that, then they're a U for unresponsive. So really, any level that is below alert is considered an abnormal finding. So in a trauma patient with reduced responsiveness, a spinal injury, um, uh, a spinal injury is going to still be a major cause for concern, and you have to take that in consideration for spinal motion restrictions and how you want to treat and plan for this patient. Um, yeah, so it's always good to also look at witnesses, again, family members. They can always provide information if the patient can't. Again, that could be the events, the chief complaint, or just history of the patient, allergies, medications, things of that nature. So when a spinal injury is in consideration and possible, again, as we talked about, one individual, one EMT should support the head and neck while the airway is being assessed. You want to start with the jaw thrust maneuver again to in the hopes of not manipulating the head and spine. If the jaw thrust actually fails to open the airway, you can use a different technique to establish airflow. Um, you could try to drop an OPA, an MPA. The head tilt chin lift should be one of the last resorts because we don't want to cause debilitating injury if we don't have to, but we also need to ensure that airway is open. After you open the airway, you want to ensure that the suctioning is ready just in case. Um, or at least on standby. Head injury patients are prone to vomit, especially if as their consciousness kind of starts to decrease. If suctioning can't clear the airway, then you're going to have to roll the patient. Again, do your best to do it as one solid unit so you're not manipulating the head and spine too much. And then you have to remove the items from the patient's mouth. Okay. And as always, continue on with your assessment of their breathing, breath sounds, effort rate, rhythm, tidal volume, SpO2. Because again, we're thinking if there's any irregularity there, you could have some type of brainstem dysfunction, brain herniation that could produce, those irregular breathing patterns, apnea, or just inadequate ventilations overall that require more aggressive interventions. Um, so to continue on, oxygenation again and ventilation. We already talked about it. It needs to be monitored. Your pulse oximetry estimates O2 saturations in the blood. You can also use something called capnography, which can measure the carbon dioxide that's actually being exhaled by the patient, and that kind of shows you how effectively the patient is ventilating. For suspected TBI, you want to position the airway appropriately to provide oxygen, and you're really trying to maintain that SpO2 level between for the text going to be 95 to 99%, and then obviously you need to take more aggressive actions if it starts to fall below 90%. But if breathing is inadequate in terms of mechanically speaking, that's where positive pressure ventilations should come into play to ensure you have enough volume just to see chest rise and fall. Now, if you're using an end-tidal CO2 detector, um, you're gonna want to target for a 35 to 45 millimeters of mercury in that sweet spot of carbon dioxide during their exhalation. Because routine hyperventilation is going to lower your carbon dioxide. It can also constrict cerebral blood vessels and reduce blood flow to that injured brain. Okay. So temporary mild hyperventilation may be considered, but only when there are like clear signs of imminent herniation, and that's where capnography is available. And you need to have capnography available, and if it's your protocol allows it. Okay. But again, in that situation, you want to where there's a potential for brain herniation. Because again, the whole purpose is to try to stop blood flow to that area. But you want to try to have an end-tidal CO2 between 30 and 35 millimeters of mercury. So moving on, also need to assess circulation. Obviously, you want to start with the pulse, look at their skin signs, check blood pressure, and then again treat any type of possible bleeding at this point of the non-serious matters. So you should have already kind of took care of that. A slow pulse during a serious head injury, again, can indicate there's rising intracranial pressure. But again, when you're looking at that coupled with increased systolic pressure and blood pressure and irregular breathing, you got to think about increased ICP. Hypoperfusion. So hyperperfusion can happen. Typically, it's a little bit later assigned, but in this context, that just means that the brain and other tissues aren't receiving adequate blood. And when we're saying blood, we're like also referring to oxygen. So even one like little episode of hypotension that can worsen that secondary brain injury we talked about. So it's very important to identify and treat shock very early on. And again, look beyond just the head for that blood loss, right? Uh, During these traumas, again, injuries can happen all over the body. So the chest, the abdomen, the pelvis, long bones, those could all be sources of real significant internal bleeding. So control any visible hemorrhaging while also maintaining head and neck alignment. Um, and it's also important to note, and for treatment, when you have a skull fracture that's depressed or you just in that area, you want to try to avoid palpating really rough, right? So you don't want to go too hard on it because there's always that potential that you push those fragments into the brain a little deeper. The last part of your primary, again, should include your plan of action of how you want to treat the patient, um, either initially or what kind of do you want to stay and play? Do you want to load and go? Where's ALS? Do you need ALS? Where's the closest hospital? So transport is always going to be a very critical element because these patients typically need definitive care. So, your plan should begin during your primary assessment. A patient with an impaired airway, not breathing good, open head wound, abnormal vital signs, signs of shock. Um, those patients need, rapid extrication from the scene and immediate transport. Okay. Now, during transport, again, you're going to continue monitoring their airway, oxygenation levels, ventilations, make sure hemorrhaging has been controlled. Um, and again, you're just moving them as quickly and efficiently towards definitive care. Okay. Um, Transport a patient with a suspected TBI, again, to an appropriate trauma center when it's possible. There are times where you might have to decide, you know what, we need to do medical transport. But again, that's only when there is, meaningful reason, right? So that shortened transport time from helicopter versus ground is going to make a significant impact on that patient's care and well-being. Now, for a supine patient with, again, that suspected ICP, but they also have adequate circulation, you're going to elevate the head and upper body by about 30 degrees. Hopefully, that's going to help support some venous drainage. Uh, but again, you want to make sure you're elevating the entire patient in like a Trendelenburg type situation. But again, that only if is inside your protocols. But that is one, in theory, way to reduce some of that blood flow to the brain. Now, once immediate life threats are controlled, this is when we're going to gather the history while the patient can actually still communicate with us. So you really want to begin with the event itself. What happened? Where does it hurt? Did the head strike anything? Was there any loss of consciousness? Was there any pain in the head, the neck, the back? Right. Ask whether the patient actually can feel and move their hands, their feet. Try to identify any type of memory gap either before or after the injury. And then, of course, complete your sample history, as time allows, whether that is on scene or simply in the back of the ambulance as you're on your way to the hospital, right? So, again, sample signs and symptoms, allergies, medications, pertinent past medical history, last oral intake, and the events leading to the situation. Now, a patient may still have a spinal injury while the person's walking around. They can still move every limb. They have total, complete sensation, and they have like maybe even little to no pain at all. Right? It's because the vertebrae or those like supporting ligaments can be damaged while the actual spinal cord can continue to function. Okay. Pain also could be hidden by, intoxication, confusion, or some type of other severe injury that's distracting the patient. Now, it's because of that reason that these reassuring findings can't independently clear the spine. Okay. So you still want to, if the mechanism of injury is still significant enough, and there's any sign of neurological dysfunction at all, you still want to ask the patient to be still. Avoid testing the neck by asking them to turn, bend, extend, anything like that. That would potentially put more stress on that injury. And then just continue your assessment in the position that it was found, whenever the airway, circulation, and the scene condition will allow it. Now, your secondary assessment again. You might complete a head to toe examination or a focused assessment, okay, depending on the situation. Now, if there's a major collision, a significant fall, some type of injury where there's multi-system type injury situation, that usually would call for a head to toe situation where you're systematically going to go and look for any injury at any compartment, just because the MOI was so significant, right? But now a stable patient with a clearly isolated injury, that's where you're probably going to do more of a focused assessment and just going to focus on that one injury, take care of that, and then you might do a more rapid head to toe just to see if there's any other injuries that were missed. But for a critical patient, this examination, it can continue during transport, especially if the baseline vitals, which again, the baseline vitals is like the first set of vitals that you've obtained from the patient, like your breathing assessment, pulse check, skin signs, blood pressure, neurological status. Once that has already been completed, and if things aren't looking the best, then and the patient's not looking stable, then you can start kind of packaging it up as and after all life threats are taken care of. And then complete the head to toe in the ambulance en route to more definitive care. Um, so so pulse oximetry and capnography could be utilized to monitor the patient's oxygenation, their ventilation status, and you want to make sure you're following the targets that are established during your primary assessment. A patient's blood glucose, body temperature can also really help identify other causes of their altered mental status and any type of complication of their neurological injury. The use of DCAP BTLS, again, so this is a part of your head to toe examination, but also your focus assessment. This is the clear um, generic traumas that can be at any body region, right? So we have deformities, contusions, abrasions, punctures, burns, tenderness, laceration, and swelling. So before we actually, and then, so that's going to be again the traumas we look for. Now, before we actually move the patient, we need to assess perfusion, motor function, sensation, and all four extremities. You want to compare them to both sides. So we're comparing bilaterally. So for this one, you're going to ask the patient to either depending on the situation, you can have them squeeze your hands, wiggle their fingers, touch finger, like what toe am I touching, what finger am I touching, check pulses. It's up to you. Now, if there's an actual injury to those extremities, I recommend not doing the grips or the pushes and pulls, just because you are um, causing manipulation of that area, which is going to cause more discomfort and more manipulation of that injury. So just doing the motor control, as in wiggle your fingers, wiggle your toes. What finger am I touching? It's a lot easier, and less chance of causing any type of aggravation to the injury. Now, if you're kind of concerned more about just neurologic status, like a head and spine injury, and there's no injuries to the extremities, at least major injuries, then yeah, doing your grips, doing your pushes and pulls is going to help tell you if there's actual like motor dysfunction and like strength differentials between the right and the left side. That is fine. But really continue watching the patient's level of consciousness throughout your secondary assessment. Any confusion, patient asking the repeated same questions, if there's any type of delay in their answers, they feel fatigued and like kind of getting tired. This could be early signs that that brain injury they're having is just getting worse. Um, Again, inspect the scalp, the ears, the nose, mouth for any type of wounds, any type of blood, any clear drainage from the ears and nose, or that actual injury site. Look around the eyes, behind the ears for the potential fracture signs that we kind of covered earlier with the raccoon signs, battle signs, raccoon eyes, battle signs. Establish a pupil baseline, again, comparing the size of the pupil, symmetry, and the reaction to light. Really, a difference greater than 1 millimeter may be significant after trauma, particularly when it's a new finding. Okay, a pupil that actually remains large and reacts very little to light can indicate increasing pressure on the brain. Repeat examination. You want to repeat the examination because, again, any change from the original finding may be important, even more important than just that one isolated baseline vital sign, right? Again, avoid pressing on any of those obvious skull depressions or placing any finger into an open scalp wound, because that could easily move the bone fragments toward the brain and causing more significant injury. If there is an impaled object in place, you wanna leave it, you wanna stabilize it, and do your best not to move it at all. Removal is considered really only if the object directly prevents life-saving airway care, or if it interferes with CPR. Your Glasgow Coma Scale, again, your GCS. This gives us a really consistent way to just measure a person's neurological function. Again, it scores in three observable responses: eyes, verbal, motor. It just establishes a baseline score. And you want to do this as early as practical it practically allows. Record the time and then repeat it whenever the patient's mental status changes, because again, those trends are going to be significant. And for the most part, you should get enough information, pretty much at your general impression, your AVPU, to get a baseline GCS score. But really, a patient's whose score is like falling or failing, maybe developing a bleed, swelling in the brains, hypoxia, or just getting less perfusion to the area. So just report what the patient is actually doing, as well as a score. So, confused about the date, or they open the eyes to pressure, or communicates more clearly than just the vague descriptions like, oh, they seem dazed and confused. And if your specific system allows it, you're going to use a revised trauma score, and the GCS just becomes a part of that entire calculation. So again, there's a little deeper into the GCS, the Coma scale. Again, it's an eyes verbal motor kind of system. So it's just how is that patient responding in those three categories to stimulus, right? For eye opening, 4 points, and it's a 4, 5, 6 scale. Max score is a 15, low scale is a 3. So for eyes, it's our first category. The max score is a 4. Okay. Now you get a 4 if your eyes open spontaneously. That means more so you arrive on scene and the patient's going to start tracking you as soon as you're there, right? So that you don't have to say anything; they're immediately just looking at you, because that's what a normal situation would call for, right? But now let's say they're not, right? They're not looking at you when you arrive on scene. Like, okay, that's kind of weird. Their eyes could be shut. They could just be staring off into space or looking somewhere completely different. And it takes you to actually say something like, "Hey, sir, how you doing?" And "Hey, bud, can you hear me?" And that causes their eyes to either open or shift towards you. So that would be they respond to verbal stimuli, and that'd be a 3. Now, if you do that, like, "Hey, bud, can you hear me?" and they don't respond, they don't look at you, their eyes remain shut. You're like, "Okay, that's weird." So then we go into our noxious or our painful stimuli, and we do our trapezius pinch, or again, whatever your protocol allows, sternal rubs and whatnot. If their eyes open or they look at you, now they're a 2 on the GCS for that category. Now, if you do that trapezius pinch, or painful stimuli, and they don't open their eyes or move their eyes at all, then they get a 1. All right, so perfect. We're good there. Now, at the same time, you're also evaluating how they're responding verbally and how they're responding motorly to these stimulus. But again, we're kind of breaking it down piece by piece. So, in terms of our verbal response, the main max score is going to be a 5. The low score is going to be a 1. So, a 5 means the patient is oriented. Okay, so that means they're communicating clearly. You're asking them a question and they immediately respond with a correct answer. Now, a 4 is the patient is confused. Okay. Now, confused is specific. They're still answering the correct question with their correct answer, right? So if I ask them, where are you right now? And they say, "Oh, I'm in my living room," and you're actually in the living room. But it kind of took them a second, and they had to think about it. They're still like, "Oh, where are you?" And they're like kind of pondering. They look kind of like out of it. They're like, and then they say, "Oh, I'm in my living room." Okay, that's confused. Okay, because a normal functioning capacity brain would just immediately be able to tell you that. Now, if I were to say, "Oh, sir, where are you right now?" And they say, "Oh, I think it's Tuesday," right? That's not the question I asked, and so the response was actually inappropriate, right? That was an inappropriate response to my question. It was still words, it was actual words that they produced, but it was just an inappropriate response to the question that I asked. So that would receive a 3. Okay. Now, this next one is typically found with a painful stimuli, but it can still be a verbal. And it's basically just incomprehensible sounds. So if I say something to that patient like, "Hey sir, can you hear me?" and they moan, "Ugh," or you do the trapezius pinch sternal rub and they just kind of moan or groan, that would be an incomprehensible sound, and that would be a 2. Okay. But now, if I did my verbal and painful stimuli and they didn't respond anything verbally to me, then that receives an unresponsive, and there are 1 on that scale. Lastly, we have motor. Okay, so motor is a 6, a max of 6 score. Low score is a 1. A 6 means that they actually follow commands. So if you arrive on scene, the patient's standing up, you tell them to sit down, and they sit down. They follow commands. You ask them, "Oh, sir, can I see your hand so I can take your pulse?" And they do it. That's a follows command. So that's a 6. Okay. Now, these next few are more related to a painful stimuli. So they didn't respond in terms of, "Oh, can you like do something for me?" So they're not following commands. So you do your sternal rub or a trapezius pinch, and you have some type of purposeful movement. Okay, typically they're localizing the pain. So let's say you're pinching the trapezius muscle. They're kind of out of it or completely unconscious, and they're trying to like push it away. That would be considered a 5 for purposeful movement. Okay. And they're able to localize pain. Now, if I did that same trapezius pinch and instead of them kind of pushing it away with their hand or their body, and they start kind of going away, they're like pushing away, their whole body shifting away, but they're still looking unconscious. That would be they're withdrawing from pain or pressure, if we want to kind of be a little more technical. And that would be a 4. Okay, that'd be a 4. Uh, the next two, though, is kind of what we talked about earlier, and when in terms of decelerate and decorticate posturing. Okay, so this is a sign that they have increased intracranial pressure. So if I do my trapezius pinch, and all of a sudden you see the arms kind of curl in and like flex into the body, we call that decorticate posturing or flexion posturing. Okay, so the arms will go in. Okay, now if you do that, and that's going to be a 3. Okay, now if I do the trapezius pinch and you see the arms extend out, the legs extend out, that would be decelerate posturing, and that's extension posturing. Okay, and that would be a 2. And if you did the trapezius pinch and they didn't respond anything in terms of movement at all, they'd be an unresponsive individual, and that would be a 1. Okay, so again, you're going to calculate all that up, document exactly what they were in terms of like how do they actually respond and whatnot, and that would give you your numbers. Okay. Um, and yeah, so this is an important element to gather in your assessment for a baseline check of the patient, and then you're going to every 5 minutes or 15, depending on the situation, reevaluate and see if they're trending upwards or downwards or staying the same. Now, during your spine examination, you want to inspect, palpate the accessible areas for, tenderness, instability, crepitus. Again, you're looking for those step-off fractures, looking if the vertebrae are aligned. Still looking for that decap BTLS. Still checking for circulation, motor, and sensation in all 4 extremities. If a deficit is present, describe where it begins. Because an exact nerve root diagnosis is going to be unnecessary in the field, but a clear description like no movement or sensation below the waist, right? That's a little bit more useful. Okay. A severe spine injury, especially of the spinal cord, that can cause complete paralysis, loss of sensation, loss of bowel and bladder control, and it could be anywhere below the actual spinal injury. Now, high cervical injuries can also impair breathing. And that's mainly because of the phrenic nerve activates the diaphragm. That is from the C3, C4, and C5. So again, keep that in mind. Depending on where the injury is in the spine, you can have a systemic reaction. Okay. Now, other signs of a cord injury includes a priapism, which is a sustained erection in our male patients, and difficulty regulating body temperature. So again, because the brain and the spinal cord control so many aspects of the human body, an injury to the head or spine could have a major impact in a variety and diverse, unique ways. So here we have a nice little diagram. So the level of the spinal cord injury just helps kind of predict how much of the body can be affected. Okay. Now, a cervical injury can impair the arms, trunk, the legs. This pattern is also called either quadriplegia, tetraplegia. A lower injury may leave the arms functioning while affecting the lower trunk and the legs, right? So that would be called paraplegia. Now, the pattern is not always like a complete or perfectly even, right? So an incomplete cord injury may preserve some movement, some sensation, and one side may function better than the other. Okay. A complete injury, though, produces a more like extensive loss below that neurological level. Okay. Higher injuries, again, generally affect more of the body and can create a greater concern for that breathing aspect, again, because of that phrenic nerve innervation. The diagram, again, provides just a broad kind of guide, while, again, this is the more the patient's actual movements, their sensation, respiratory effort, that determines what immediate care and treatment that patient needs. Now, again, your reassessment is just a repeating cycle of your assessment, right? It's not necessarily your final thing you have to do. It's just you're going to do everything again, right? For a more serious injured patient or potentially unstable patient, again, you want to repeat this at least every 5 minutes. And again, reassess immediately whenever the condition of the patient changes. So you don't have to just wait till the 5 minute timer happens. If anything is changing on that patient, just do a complete reassessment. Okay. And if they're unstable enough, then you really should just be continuously monitoring, not just kind of hanging out in the ambulance doing your paperwork. Again, continuously talk to the patient, look at checking the monitor, whatever your situation is. But you want to keep an eye on that patient. Um, and you typically will start with just doing your primary assessment again, checking out all those vital signs, talking to the patient, see if their mental status has changed. But again, another important aspect is to ensure that your interventions are still active, right? They're still working. And then based on that, how their vital signs are, whether or not you need to make any changes, right? So in terms of like bleeding, so confirm that the bleeding is still controlled, right? Make sure the patient's airway is still open. Make sure they're breathing adequately and circulation hasn't worsened. Repeat your vital signs, their neurological assessments. Check their pupils, check their CMS and their extremities, and then again compare those new results to the baseline results. Okay, because that's how you're going to get a trend, right? A patient's failing GCS, new pupil inequalities, increasing weakness, or changing in respiratory patterns, that could all indicate that there's deterioration going on. Um, and yeah, in terms of your interventions also check, the oxygen, right? So if you're giving the patient oxygen, has that impacted their SpO2 level, their skin signs? Has things stayed the same? Have they gotten worse? Do you need to increase your oxygen liters per minute delivery? Do you need to change the method in which you're delivering oxygen? All of this should be being applied during your reassessment. Um, yeah, as I talked about just now, you're checking your interventions to see if they're working. After beginning positive pressure ventilations, you want to make sure that there's still adequate chest rise and fall. You're continuing monitoring those O2 saturations. If you're using end-tidal CO2, you're making sure the patient's still within that 25, 35 millimeters of mercury kind of range. If the results, are poor, you got to reassess, right? Reassess the airway. Make sure your seal is good on your mask. Make sure your ventilation rate is good. Make sure your delivery volume is good. Make sure you're not applying too much of the BVM. You're not giving too much air into into that chest cavity. After you apply a spinal motion restriction, SMR, confirm that the head is still aligned, the equipment is secure, breathing isn't restricted. all kind of plays a role in your reassessment. So there's a lot more to do than you might actually think. Your CMS check should go again. And then for shock, compare the pulses, make sure that your blood pressure is checked, look at their skin signs, look at their mental status. Again, any subtle change in a patient's awareness, their speech or responsiveness, again, that could be an early indicator that the patient's deteriorating, and you can take steps now to try to combat that. Again, the CSF, that's that, again, clearish, watery drainage from the nose, ears, maybe an open scalp wound. Again, that just indicates that there is an injury to the meninges. You're going to allow it to drain freely. Okay. So you're not going to like stuff anything into the ears or the nose. You're going to have like loose dressing taped over the ears or over the nose. The goal more so is not to stop it, right? Because the injury is deep inside the skull. Okay. So it's not like you can stuff a bunch of gauze in there to kind of put pressure on it. That's not going to happen. So really what you're trying to do is cover the openings from the environment. So it's going to reduce the likelihood of contamination, which hopefully means you're not going to get an infection and more specifically some type of meningitis. Um, yeah, so continue, again, in this situation, also continue oxygenation, ventilation support. Um, you should have already applied a cervical collar, so make sure that still the patient's head and spine are aligned. And yeah, just keep on assessing as you're on your way to the most appropriate facility, which usually be a trauma center in a significant case of a head or spine injury. Now, communication and documentation is always an overlooked element. We can go all the way back to like the first week of the program in chapters 4, chapters 1, and understand how important documentation is and how important communication is, right? So the receiving facility here, they really need a clear picture of both the injury and the patient's progression, okay? So you're going to report the mechanism, any significant findings, the GCS, the pupil. Again, you're going to have a specific script, preferably, that your company should provide. But more so, you're going to let the receiving hospital know the age, sex, weight of the patient, what's the chief complaint, what's the pertinent history, allergies, meds of the patient, what are their current vital signs or trends. You're going to let them know what treatment you provided. Has there been any progression or change in the patient's condition, like the response? And then lastly, how long till you get to that facility, which is kind of often overlooked. Are you 5 minutes out? Are you 10 minutes out? But the receiving facility just needs to know, hey, what are they need to be prepared for? Is this so significant that they need to have like all hands on deck? They need to page surgeons and whatnot, get everyone kind of ready to take this patient to provide the best care and the most expedited care, so to speak. Moving on to emergency care, right? So this is now how we actually treat it, a little bit more specifics. Now, in terms of the care for head injuries, this can actually be organized, categorized into three specific priorities, right? Your first should be to maintain cerebral perfusion, and we do that by controlling bleeds, supporting circulation, preventing hypotension. Okay. Now, the injured brain still depends on that steady, constant supply of oxygenated blood. Okay, so we need to take important steps to make sure that isn't disrupted. Second, we need to make sure there's a maintained open airway, adequate oxygenation, and then adequate ventilation. Okay. Any airway obstruction, hypoxia, ineffective breathing, that can easily, very quickly worsen a secondary brain injury. And then third, establish a baseline, a neurological baseline, and just continue monitoring, right? It's really important to track that level of consciousness, their GCS, their pupils, their CMS. That way you can kind of detect a deterioration fairly early on. Now, again, these priorities are just managed together throughout care rather than completed one at a time, right? So again, you learn things, and again, I try to tell you guys all the time. In class, you're more learning things chronologically, right? Oh, do this in like sequencing. Oh, do this. This is the priority. Then this and this and this. But that's because if we told you, oh, you got to do all this at the same time, and you didn't have any structure, you would just get like kind of flustered, right? So right now we're trying to teach you these are everything you need to be thinking about, be treating, be assessing for. But we do it one at a time, just because that's how your brain needs to kind of get it all in there. But then once you actually progress and you memorize all the steps, you memorize everything you're supposed to be looking for. That's when you progress to actually being able to multitask, right? You're assessing and treating a bunch of things all at the same time. Okay, so right now things are kind of hopefully in the semester, because again we're teetering on the end of it. Um, you should be progressing to that point where you're starting to gather that information. You're starting to actually understand it. You're starting to see the whole picture, right? Instead of just little pieces of that puzzle, and you're like, what picture does this make? Right now, you should be able to kind of see a little bit more, right? And if you're not, that's okay. Okay, you just got to work on it, and it takes practice. So it takes a lot of practice. Even, you're going to pass the course, you're going to pass nationals, um, and you still might not feel like you're ready, and that's totally okay. Most people aren't going to feel ready. It'd be kind of surprising if you did feel ready. If you did, you just don't know what you're getting into. Because you don't know until you know. You don't know until you're actually out there, actually running calls. You got hired. You're doing it for real. Okay. So that's when you actually know, and you see how fast paced it is. You see how different and the same it is from school, right? It's the same because a lot of everything you learned is still there. It's still out there. It still can be evaluated, but it's different because it happens so quickly that you're missing it, right? You might not be able to see it. You might see a seasoned EMT and paramedic only ask half the amount of questions that you're taught to in school. But in reality, they're asking more questions than you might think because they're seeing it on the patient. They can actually see it, they're digesting it. They don't need to be so specific with every little inch of question, every little specific question. Um, so you're going to think like, oh, I didn't need to memorize all that, but you did. Okay. But that's going to come later on. That's going to come later on. So don't feel bad, right? Don't feel like you aren't prepared, that you're not ready, because that's another common thing. I know I'm going on a tangent. That's another thing that commonly bothers me, and I try to fight that as much as I can. Near the end of the semester, students want to give up, right? They can be passing all the exams. They're right on the doorstep of passing, but they actually want to quit. They want to drop out because they don't feel like they're ready, right? They don't feel like I can start tomorrow and be a fantastic EMT. And you're not expected to, right? You're expected to be a competent EMT, right? You're expected to know things. You're expected to be able to function. Someone tells you to do something, you know how to do it, and to kind of, do what you need to do on scene. They're not asking you to save every patient. They're not asking you to be the one in control, because it's little steps, right? You're going to be a brand new EMT. Eventually, you're going to get that experience. You're going to get that exposure. You're going to get that confidence, but that takes time, right? So you can be more confident by learning more, by retaining more information, and by practicing. But you're not going to be the greatest EMT the first day out of paramedic school or EMT school. The first day that you pass the national, you're not the best EMT in the world, right? And nor should you think that. But you do have the capacity to be the best EMT. So that's what you should do. So don't get discouraged. Just do your best, and then be a lifelong learner, right? A lifelong student, if you will, because the job's never done. You don't what you learn in the EMT school, what you learn in paramedic school. That's just the surface, right? There's so much more to learn in experience. So yeah, that should be a whole nother video I should talk about. Moving on. Airway management. So this is a touchy subject apparently in my class, but airway is always a priority, right? I always say, obviously you need to open up the airway, right? So you need to open up the airway, make sure there's no obstructions, but there is always an obstruction in there, right? You always have an obstruction inside the mouth, okay? 99% of the time because it's the tongue, right? The tongue is always a potential obstruction, okay? Unless the person doesn't have a tongue. So there is always a possibility that tongue flops to the back of the throat, slides on back, and now mouth is now obstructed. Okay. Now you could again use a maneuver to open up the airway, which again, either the head tilt chin lift or the jaw thrust maneuver. Now, in a trauma type situation, especially when we're talking about head and spine, you should be using a jaw thrust because the whole point of the jaw thrust is to open up the airway, which means you're moving the tissues like the tongue away from the back of the throat by again moving the mandible more anteriorly, which then also moves the tongue and the tissues away from the oropharynx, specifically the back, or I guess more posterior to the pharynx. Um, so you can have an open airway where air can actually go in and out without any issues. Um, but to actually maintain that airway, okay, to maintain that airway, you'd either have to maintain that maneuver, so that head tilt chin lift or jaw thrust in this situation. And that's really going to take your partner or a resource out of the patient care aspect, right? Because now they can't do anything else. They're just locked in, making sure that airway stays open. Now, yeah, they could be bagging the patient, which would be good. So you can kind of maintain that maneuver. But in reality, you should be dropping. Again, this is more my thought process and in my and it is actually in our protocol to drop an OPA or an MPA, so an oropharyngeal or a nasopharyngeal airway. Okay, and that will just prevent the tongue from flopping to the back of the throat, so that airway is going to stay open and be maintained. Or if the patient has a gag reflex, you drop an MPA, a nasopharyngeal airway. So now you know you have an opening from the environment down the nose to the back of the pharynx. So that is kind of the goal there. Um, Now, yeah, if the patient has a gag reflex or has broken damaged teeth and tongue, or their teeth are clenched, you can't use an OPA, but use an MPA. Now, again, depending on your protocol, national protocol, I believe is still if they have facial trauma, you don't want to do an MPA because you might inadvertently tickle the little brain. Here in county, we can do it still. So take that with again, follow your local protocol. But again, airway management, making sure that the airway is open, clear of obstruction, no blood, no vomitus, no broken teeth. So again, have suction available, whether it is a automatic suction or your manual pump suction. It should be readily available to suction the patient's mouth. Now, again, once the airway is open, you need to maintain that head and neck in a neutral inline position. So somebody is already holding C-spine precautions, because again, you have a head or spine injury. Okay, even when the C collar has been applied, that partner needs to hold C-spine precautions until they are completely secured to a backboard. But again, that is depending on your local protocols. Always keep the mouth accessible, right? So you always want to be able to see inside the mouth in case they start to vomit, and so you can have suction as needed. Because a person can easily start vomiting once they become a little bit more less responsive and very little warning. So you don't want to, you can't just kind of easily tip them over like a normal patient would, because again, you're concerned about a head and neck and spine injury. So here we have very good teamwork. We have spinal motion restriction being applied, and then we also have a C collar being applied. Very important to know what equipment you're using. Here, look at the screen. It looks like they're using the Laerdal cervical collar, which is the collar of choice nowadays over out here in for AMR for LA County. I personally like the Ambu one. I don't know if it's more of it's what I used back in the day. So I just kind of, you're going to find you just kind of tend to gravitate more towards things that you used. I will say the Laerdal is a little bit more user friendly for sure, because you only have like two little tabs you got to pop out, and then you can resize it, measure it, all that good stuff, and then pop it back in. Where the Ambu brand one, you have to like flip the chin thing, which is always forgotten. There's like four other little things you got to unpop, and then I don't know, I just think it looks cooler. It's fine. But again, it has the same function. Okay, there's again more there's more than one way to skin a cat, as Mr. Shot would say. Now, again, so for a C collar itself, you're having someone maintain spinal motion restriction, right? You're going to ensure that that patient does not move their head. If they're even a little conscious, you're going to again communicate with them throughout. Then your partner is going to size and then place the C collar itself. Again, follow the manufacturer guidelines for all of your equipment in terms of how to measure. Typically, you'll put your fingers alongside the neck on top of the trapezius and then measure how many fingers it is to the angle of the jaw. And then that would be the sizing kind of parameters you would use, and you would adjust the C collar appropriately. When you're applying for it, it does take practice. So do take the time to practice in your lab of how to apply a C collar in the most effective way. Me personally, I like to apply the anterior part of it first, so right to the neck, so I can kind of stabilize it right there. Then I would take the back strap, I kind of fold it, slide it behind, and then Velcro it in place. I find if the ones that kind of have to slide underneath the neck first, like behind the neck, and then they kind of wrap it around, there's a unless you're perfect on your angle, you're going to be kind of off centered, and then you just have to kind of readjust. Another important aspect is to look out for the patient's hair, especially if they're conscious, because again, there is a lot of Velcro, so it's going to start tugging on their hair. So try to get their hair out of the way, especially if they have long hair, just without manipulating the head or the neck slash spine. Um, Yeah, so after you clear the airway, assess whether the patient's ventilating effectively, check the rate, depth, regularity, tidal volume. So, again, in the field, tidal volume is just the chest rise and fall. You're going to provide supplemental oxygen, again, based on the patient's condition, based on the targets that you have, right? Um, if respirations themselves are too slow, too shallow, that's when you're going to assist with a bag mask device, or if you're breathing too fast. Again, depending on your textbook, I believe our textbook says greater than 28 or less than 8, might be 10, less than 8, you're going to start bagging the patient, okay? Because they're breathing way too fast to actually get air and oxygen into the lower areas of the alveoli to actually have oxygenation, so the usable air, but you're also getting a lot of carbon dioxide out, which is also bad. And if you're breathing slower than 8, you're not breathing enough to actually sustain oxygenation levels for your body. So those are both problems. The other one is if you have low tidal volume. So if you're breathing if the chest, you can barely see the chest move. They're breathing shallow. They're not getting enough air inside of their lungs to the alveoli. So those are the reasons why you would start to bag a patient. Okay. If the patient is mechanically, okay, that's the key word, mechanically breathing adequately. So they're breathing in that good range. So let's say between that 10 and 28, somewhere in between there, and they have good tidal volume. Typically, they'll need oxygen if their SpO2 levels are low, if they're showing signs of shock, have poor skin signs, pale cool diaphoresis, cyanosis. Then a non-rebreather mask would be a little bit more appropriate because again they're breathing fine in terms of ventilate of mechanically, so they just need higher concentrations of oxygen to get down into their alveoli, into their blood, and then they'll start having more oxygenation throughout their body. Um, Again, so it all depends on the situation. Now, if you are in this situation where you're bagging a patient, again, an airway adjunct should also be used. Again, if the patient can't maintain their own airway, and a patient cannot maintain their own airway if they're unconscious. Okay, so if a patient is unconscious, they cannot maintain their own airway. Now, they might not have snoring respirations where that tongue is kind of flopped to the back. They might not. They might actually still actually be breathing, so they have some type of chest rise and fall. But it doesn't mean that it's going to always be like that, right? So I don't think there's any harm in dropping an OPA, okay? And if they take it, that means they don't have a gag reflex, then perfect. Then now we know that the airway's maintained. We can start bagging the patient with no worries. But if at any point they start to gag, we just plop that guy out. Easy as that. And then again, your O2 saturations, end tidal CO2, very important monitoring tools. I never like using just one as a sole decider of what to do for a patient, right? So I don't necessarily want you to look at the SpO2 and know exactly what I should do, right? Now, sometimes a little bit easier, if they have a very low SpO2, you're like, all right, well, they need oxygen. But what kind of oxygen, right? Are you going to give them a nasal cannula? Are you going to give them non-rebreather mask, simple mask, Venturi mask, BVM, CPAP? It depends. So again, you need to look at more than just one little thing to make a clinical decision. Okay. Now, looking at end tidal CO2 is also plays a role, but again, a little less you can do with that as an EMT. But again, it's just pertinent information, good information to have. And if that end tidal CO2 and SpO2 is kind of getting worse, possibly there's having increased intracranial pressure. You never know. So again, it's all about documentation. That way you can best treat the patient, but then also the nurses, doctors, and the team at the hospital can also better treat that patient. Now, circulation here begins with checking for a pulse. Now, again, how I like to teach the trauma assessment is when you arrive on scene. Again, you're doing your BSI, your PPE, doing your scene size up, checking everything out, using your Penman mnemonic, making sure everything is good. Awesome, perfect. Then we go into our general impression, right? So we're just kind of characterizing the patient, kind of their overall disposition. So, what's their approximate age, sex, weight? I'm looking at their eye tracking. I'm looking at their overall, their skin signs, their body positioning, their work of breathing. How sick does this actual patient look, right? All right, perfect. Then I'll go either into my APU scoring. So I'm going to go in there and start talking to the patient. If they don't respond to me or if they're not tracking me, like, all right, so then I'm going to go into my painful stimuli. All right, how did they respond? Oh, they didn't respond. So then I'm going to go into my pulse check, right? So now I'm going into, and then in that general impression, I'm also looking for those life threats, right? So I'm looking for those severe bleeds. Does that patient look unconscious? Because if a patient looks unconscious, I'm assuming the worst. I'm assuming they don't have an open airway. I'm assuming they're not breathing. I'm assuming the worst of the worst, so I can be more aggressive with my approach and treat those life threats. So when the life threat comes in of possibly being unconscious and have all those other variables, I'm going to go in with my APU scaling. So, like, all right, let's go ahead and do my trapezius pinch, my verbal stimuli. How did they respond? Did they respond? Did they not? Let's say they didn't respond. So now I'm going to go ahead and check pulses. I do like it when my students will check a carotid pulse and a radial pulse for a trauma at the same time, right? Uh, the carotid pulse is a central pulse, one of the last pulses to go because it's more directly linked up with the heart, so it should have the most pressure. So you should be able to feel that if the patient's heart's actually working. Now, the radial pulse is on the periphery, right? The peripheral pulses, so it's gonna you need more blood pressure to actually get that far. So if I check a radial pulse and check a carotid at the same time, if the patient has a radial, they're gonna have a carotid, right? But if they have a radial, I know that blood pressure is at least like 80 millimeters of mercury, right? I can't remember if that's the exact number, but you know there's like a minimum of that blood pressure. So they have some blood pressure. Awesome. If they didn't, I'm like, okay, that means their blood pressure is kind of low, but did they have a carotid pulse, right? Let's say they had a carotid pulse, but no radial. Now I'm thinking their blood pressure is much lower because they don't have enough pressure to actually get all the way to the radial pulse, the radial artery to actually have a strong pulse. So that could be a problem. But if I know they have a carotid, at least I know they're alive. I'm just thinking they're in some type of shock potential, and I can kind of treat that way. Then I'll go to airway and their breathing. Okay. Typically, you would again do it at the same time because as I'm down there, I'm feeling right. I'm not. I don't need to do. I don't do any counting. I'm just saying, hey, how fast is the pulse? Is there? What's the rhythm? What's the quality? Perfect. At the same time, I'm looking to see that patient breathe. Right? Do I see chest rise and fall? Do I hear any breath come out their mouth? Do I feel a rush of air past their cheek? Okay. And I'm down there for how long? Right? At least 5 seconds. No more than 10 seconds. That tells you enough, right? It tells you how fast is their pulse going, right? So is it very fast? Is it slow? Is it normal? Which you're going to get with more experience because you can kind of tell what a normal pulse feels like. You get that rhythm, you get that quality. But then also for breathing, I'm looking at their how many times they're breathing. Are they fast, slow, normal? What's their effort? So do I see an accessory muscle use in the area? I can see the rhythm and I can see the tidal volume. Okay, all within that 5 to 10 seconds. But then I'm also looking at those skin signs really quick, right? So are they pink, warm, and dry? Are they pale, cool, diaphoretic? I'm getting a huge picture of this patient in those 5 to 10 seconds, right? In class, you're learning it so segmented. It takes like 30, 40 seconds to get all that information, if not more. But in real life, you get it so much quicker. Okay. So it's something you're going to learn over time. So again, as we're assessing, If the patient has no pulse, right, we start CPR, right, cardiopulmonary resuscitation. Uh, Here we use American Heart Association, but again, wherever your protocol is, as long as you follow their protocol, you're going to be fine. Um, any active blood loss, again, is going to reduce the amount of oxygen that can be delivered to the injured brain. So we kind of want to take care of that. So you do need to kind of take care of those scalp wounds very quickly, especially because scalp wounds. It's not like the scalp wounds themselves is the blood that's being lost necessarily um, to directly to the brain necessarily, but it is very vascular, so you're going to lose a good amount of blood. Okay, now to treat that again, you don't do you're going to do a light dressing. You don't want to kind of put too much pressure on it in case there's an underlying skull fracture. If you have any type of avulsion, so you have a flap of skin, you will put that flap right back on and then roll it up. But you're going to use dry sterile dressings. So here in the picture, it looks like you're using some type of gauze, looks like a 4x4, and then they're using a gauze roll to, again, secure it in place. Again, and again, it's not bleeding control as in like, oh, just do like hard pressure. It's going to be a firm pressure to kind of keep it in place. And because it really shouldn't be under that much pressure in terms of that bleed, where just direct pressure with that little wrap should really control the bleed. Okay. Shock. So shock here again in a patient with a head injury, it's going to be usually caused by either blood loss from another injury, because again it's so significant, or we're talking about some type of neurogenic shock. Where there's actual damage to the brain or spinal cord causing a mass systemic vasodilation. Okay. But your text really is focusing on your, because it was a significant impact. You could have another injury somewhere on the body, the chest, the abdomen, the pelvis, the long bones. And that's where like you can have hidden internal bleeding that's occurring, and that's why you're kind of going to hypovolemia and leading to hypotension. So that's kind of where we're at. Now, if you have hypotension, that's usually a late sign. But if you have a rapid pulse, pale, cool skin, decreasing mental status, that all supports the patient being in shock. Okay, and again, shock is widespread hypoperfusion, so lack of blood, more so lack of blood flow, lack of oxygenation. In hypovolemia, the case is you're losing blood somewhere. So now that blood is not in your circulatory system to be actually utilized. I would refer to your shock chapter to kind of get a little deeper dive into all the different shocks and kind of what's actually happening. That way I don't go on a tangent and talk about them all right now. Now, again, if you have a significant head or spine injury, you should still maintain spinal motion restriction. So again, have someone hold C-spine. And again, you should try your best to secure them to a backboard, put them on the gurney, get them out of there. If, however, the patient needs CPR or there's other life threats and you don't have the resources, you kind of might limit the SMR kind of protocol and more focus on the life-saving interventions. So it's always going to be a life over limb situation, but it's a little misnomer. A little misnomer about it is that it only applies if you don't have the resources, right? So I don't want you to all of a sudden just start moving a patient with a head and spine injury because they're unconscious and they need definitive care at the hospital. When you have so many resources to efficiently move that patient correctly without causing more undue harm potentially, then you should do it, right? You should do it. But if it's only you and your partner and no one else is coming, then it might behoove you to do what you have to do to move that patient and not necessarily not care, but not take so much effort and time into holding spinal immobilization the best you can, because it's not really feasible with only two people. Cushing's triad. Yes, so remember, Cushing's triad consists of three specific signs and symptoms. Okay, you have increasing blood pressure. Okay, decreasing heart rate, and irregular respirations. Okay, in this case, we're talking about Cheyenne Stokes or Biot's breathing. Okay, Now, a patient with a traumatic brain injury, right? This is a late warning sign of increased intracranial pressure, okay, and possibly a brain herniation. Remember, so the brain herniation, as we talked about, you just have swelling inside the brain that is starting to put pressure on the brain stem and kind of pushing that brain stem to the foramen magnum, okay, and that's again, your brain stem is one of the major factors in controlling your breathing, okay. Now the rising blood pressure. Okay, so that is more of a compensatory a mechanism, attempt to maintain blood flow through that compressed brain. Okay, the slowing pulses, abnormal breathing. Again, those indicate that that brainstem is being affected. Okay, the patient requires immediate transport. Continuously monitoring their neurological status, maintain airway, support their oxygen ventilations, treat for shock and bleeding. Okay. Any patient without like clear evidence of a herniation, you should just ventilate them normally. But again, if you have just textbook, unmistakable signs that this is a herniation, okay, this is where your protocol could allow brief, mild hyperventilation. And again, that's only really considered if you have capnography. And again, if your protocol allows it. Because again, this is gonna you're gonna target with the capnography 30 to 35 milliliters of mercury, millimeters of mercury, end-tidal CO2, and again, that's supposed to help reduce the brain swelling. Okay, that's so again. Only if your protocol allows it, and if you're comfortable doing it. This might be one of those cases where you contact base and like kind of tell them like, "Hey, this is what we have. This is what I'm thinking it could be. This is what I kind of want to do. How do you copy?" And they'll give you the A-OK or not. Once again, for now, again, this is going to be more for spinal injuries, but again, it's going to be more or less the same. The airway is always going to be a priority, right? So again, if you have a suspected spinal injury, use a jaw thrust maneuver while somebody else is holding and stabilizing the head. Okay. An OPA may be appropriate again for this a patient who's unresponsive, no gag reflex. Keep the suction ready in case a blood, vomitus, saliva. That way you can protect the airway, provide oxygen, assist with ventilation, and again, this is all dependent on the patient's vital signs, and then monitor continuously. Okay. You want to continue holding the head in that neutral inline position while the rest of the spinal motion restriction plan is kind of prepared. And then manual support, again, is going to remain necessary until the patient has been moved and completely secured and safe. So here we have a little description imagery of the jaw thrust maneuver. This one's not too bad. I've seen worse. Um, but again, the whole point is to open the airway while limiting cervical by limiting movement of the spine, right? So from a position kind of near the patient's head, you're going to support the sides of the head and place the fingers behind the angles of the lower jaw. Lift the jaw forward and upwards without tilting the head backwards. Okay. Now, moving the jaw in this direction is going to pull the tongue away from the back of the throat. You want to avoid pressing into the soft tissues beneath the chin because, again, that could actually push the tongue more upwards. Usually, if you're doing the proper technique, you shouldn't be anywhere near the chin, which is fine. What I don't like, I don't have a little laser pointer. You more want to have those thumbs on the zygomas, so on the cheekbones, because as you're pulling on that lower on that mandible, right, that movable jaw down here, you're going to pull forward, right? So as you're pulling forward, now the jaw should be fairly loose on that unresponsive patient, but if it's not, what's going to happen, you're going to pull the whole head and the head's going to extend, right? So if I'm pushing down on the zygomas as I'm pulling up on the jaw, it's going to kind of create that inverse pressure to match each other, where now the jaw is the only thing that should be moving, and thus the tongue is moved away from the back of the throat. Yeah. So again, once the life threats are controlled, right? Once life threats are controlled, patient has, good CABs, ABCs, however you want to do it. CABs technically for XCABs, XABCs. You want to start thinking about, if you have the resources, manual inline stabilization. Okay, so you're going to be behind the patient or at the top of their head, Kneel behind the patient, place both hands around the base of the skull, supporting the lower jaw with your fingers, while again your palms are going to control the head. Can't really show you from here, but you'll practice it in lab. Um, Now, when it can be done, comfortably guide the head until the eyes face forward and the nose lines up with the center of the torso. Stop the movement if the patient develops neck spasms or has more pain, numbness, tingling, weakness, or difficulty with their airway or their breathing. You really want to support the head in the position that's reach rather than applying further force. So what I'm trying to say is like it's very rare you're going to find a patient just kind of like already in line. Okay, now all of our mannequins in lab, right, they are right, they're all just kind of like just like this. More times than not the heads are going to be to the side, going to be up like this. um, so that's not neutral, right? That's not neutral spine. So you to maintain inline neutral, you're going to have to carefully move it. Okay, now carefully. Now, if the patient's conscious or if they're completely unconscious, now if they're conscious, as you're moving it, they're saying like, ow, 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 that really hurts. Then you're gonna like, all right, well, we're not gonna do that, right? We're gonna keep it right there. You're not just gonna go and go, you're not doing that. So we're gonna keep it right there. But same thing if they're unconscious, as we're trying to do it, if it just will physically not move for some reason, and again, if a person's unconscious, their muscles should be fairly relaxed, that could indicate there's something amiss, some type of injury in that spine that's not allowing you to actually maneuver it. Okay, so keep that in mind. But you do want to try to carefully put it in line, all right? And then that's where you're going to stay, and that's where you're going to live. We talked about the C collar. Again, this is again a rigid device to kind of help maintain support. Okay. Now you're going to apply this after your primary assessment. So you've already kind of got your baseline. You've controlled life threats. Everything is looking good. That's a very low priority at the moment. Okay. But now holding C spine precautions, that starts at the very beginning. Typically speaking, you want to apply it during your secondary assessment after you've already assessed the neck. Okay, so you've already observed for any type of decap ETLS, any jugular vein distension, tracheal deviation, subcutaneous emphysema, medical alert tags, scars, tattoos, injection track marks. And then again, you're going to palpate checking the carotid arteries, palpate all the musculature, the cartilage, like the thyroid cartilage, go into the back, check those C7 prominence, check the cervical vertebrae, and if all that checks out, then like, all right, cool. Now we can put the C collar on because we're going to essentially hide it, right? We're going to hide all the neck because of the C collar. Now you still have access to the anterior portion of the neck, so you can still check carotid artery for pulses. But again, you want to check it prior to applying it. Make sure it's properly sized, right? Because too big of a device will extend the head. Too small will cause it to go forward. So you want to make sure it's the appropriate size, so it fits right under the chin and then maintains stabilization. The person holding the head still holds the head, right? Even after the C collar has been applied, because the patients can easily still move. Okay, and that's what we're trying to avoid. Um, yeah, so we kind of already talked about the sizing, so I don't have to worry about that. Here in the imagery, you can kind of see how it's been stabilized to the backboard. Again, it all depends on what devices you have. Um, this specific one, kind of looking at the imagery. Yeah, I don't know what they have around the patient's neck. I'm gonna be honest with you. I'll be honest, I haven't seen this picture before. So this is the 13th edition. I'm looking at my monitors. I'm like, oh, this is interesting. We'll look into that. But it looks like it's not the patients. It's like it looks like you can. We're gonna examine this later on, team. We're gonna examine this later on. But you can see the crisscross patterns to kind of secure the head into place. We're assuming there's a C collar under all that stuff. And again, depending on your protocol, you might have these big red blocks. You might have these foam blue blocks to help secure the patient's head in place. This is also worked. It all depends on your resources, your company, your ambulance company, your department. on what they want to use, right? And typically, it should be the best practices, like, but again, if it works, it works. That's what we're all about, right? It works, it works. After you're done completely stabilizing them to the backboard, however, you do want to check CMS, circulation motor sensation, once again, in all four extremities. Again, feel the distal pulses, pedal pulses, dorsalis pedis, posterior tib, the radial pulses. Hey, buddy, wiggle your fingers, wiggle your toes. What toe am I touching? What finger am I touching? Good to go. Now, for a patient found lying on the ground, choose again. We're trying to think about transportation now. So choose the transfer method that's going to limit spinal motion while still allowing safe and timely care, right? A scoop stretcher is very common nowadays, and this one separates into two halves, and they are positioned around the patient and then are reconnected. Okay, so this allows the patient to be lifted onto the ambulance on the gurney with very little rolling. Okay, and so you don't have to do the log roll. Now, again, the log roll might be you still need to kind of do a log roll because you need to assess the back, but I digress. Now, if it's unavailable, then that log roll of you want at least four people to do this. Five would be the best, but three is really pushing it because again, you need one person holding the head, right? So they're in charge. One's holding the torso, one at the pelvis and legs. One could be at the feet. You can kind of get away without having the feet. So three, you can make it work. I like having another one at the feet, and I like having one at the back so they can kind of position the backboard in place. So it all depends on the resources that you have, however. Um, but again, use a log roll with the appropriate amount of resources, so you can place them on the backboard or a vacuum mattress if that's what your protocol has or department has, or any real SMR surface that you might have. Okay. It's always important to have the clinician at the head be in charge. Okay, so they're going to be the ones who oversee everything. They're making sure everyone has their hands in the right place, but they're making also the verbal commands. And that's one thing that's really overlooked. They have to be a good communicator. And call it out, right? So they're holding like, all right, team, and you give them the plan. We're going to go ahead and log roll the patient onto the patient's right on three. Everyone is in position. All right, log roll on three. 1, 2, and 3. Log roll. Perfect. All right, get the board in, check the back. All right, cool. Now we're going to lower the patient on three. Make sure your hands are switched. Oh, 1, 2, 3. And then down you go. Now, a vacuum mattress, again, you might not ever see it in your life, but it is out there. It really depends. It's probably more geographically specific, West Coast versus East Coast, things of that nature. But it's just an alternative device for spinal motion restriction. Okay, so it begins as kind of like a flexible mattress that's going to be filled with small beads. I'm sure most of you have seen kind of a vacuum splint, right? So you suck all the air out, and there's little styrofoam beads that kind of make it real solid. That's essentially the same kind of concept, right? You position the patient on it. The mattress itself is molded around the body as the air is removed, and this again makes it a firm, solid foundation where the patient is locked into place. Okay. It just more allows the patient to be in a neutral position where the mattress and the beads fit the contours of the body, right? And it just spreads the pressure more evenly and makes it more comfortable for the patient. Okay. Uh, Another often overlooked aspect, it provides insulation from like the cold. Okay. This makes it really useful for older patients, patients with kyphosis, lordosis, scoliosis, more so the lordosis and kyphosis, but it's just abnormal spinal curvature. Okay. The patient can be transferred with a scoop stretcher or a log roll and can be applied from the supine position, sitting, or a standing position. But again, check the manufacturer of the brand that you have for how to use it, plus what the weight limit is, right? In your chapter for this one, it describes the weight limit at 350 pounds, which is about 159 kilograms. Okay. But again, all depends on what you personally have. Now a sitting patient. So a patient who is alert, sitting in a vehicle, they may be able to move to an ambulance stretcher, or the gurney with just instructions, right? So when it's appropriate, apply a cervical collar, place the stretcher close to the vehicle, and ask the patient to keep their head facing forward. Right? They should be able to move slowly, turn their shoulders, torsos, hips together as one as they exit and lie down. Okay. Um, a short spinal extrication device may be used when the patient can't move out safely, or if access is kind of restricted, or your local protocol just calls for like greater support during that removal. But once outside the vehicle, secure the patient to the whatever device you're going to use, and then reassess their neurological function. Okay. But now a rapid extrication, this should only be used for those urgent situations where the scene's unsafe. You can't control the airway. Patient needs bleeding control. Maybe the patient needs CPR, things that where you're again, it's more of a life over limb situation. You're still going to take time to do your best not to manipulate the head and spine, but again, the priority is to get them out of that vehicle so you can start the care because that's what's going to be more detrimental than potentially aggravating a spine or head injury. Um, Real quick, on the other slide again, a Kendrick's extrication device might be used. I don't know if we talk about it in this chapter. I don't think so. But that's just one of those vest styled extrication devices. Very useful in vehicle crashes where again the patient is in a seated position in a car. It takes a little bit more coordination and effort to actually get them secured. But again, patient is stable enough, but they have textbook signs of neurological dysfunction, so we want to take extra care not to cause further injury. A patient who is standing, right? So a patient who is standing or walking, they can still have a spinal injury, right? Their ability, though, to remain upright just confirms that some neurological function is still there. But again, it doesn't establish that the spine is stable, right? For any alert patient with neck pain, you want to apply a cervical collar, position the stretcher, the gurney next to them, and then guide the patient to sit down. Then help them lie back slowly, keeping their head torso moving together. Now, you could also do a a standing SMR. Essentially, you would put the backboard right behind them. You'd have two rescuers on either side. Put your arms in, but be underneath their axilla, so their armpits holding onto the backboard. Another person's going to make sure the backboard doesn't like slam to the ground, and then you slowly take them down. You slowly lower them to the ground in one like nice fluid motion, where the backboard is keeping them aligned. If you could have another person hold that C-spine precautions as they go down, if it's possible. Now, pediatric spinal motion restriction, this just requires more attention to body proportions, right? So infants and like small children have proportionately larger heads. They have a very prominent occiput on the back of the skull. So when a young child lies flat on an adult-sized surface, the head actually is going to be pushed forward, flexing the neck, and it could potentially narrow the airway. So it's important to pad the area underneath the shoulders, the torsos, until that head and neck is in a more neutral position. Okay. Children also have, again, are narrower than adults, specifically on those big transport devices. So blankets, extra padding on both sides can help prevent the patient from sliding left to right. Okay. Also use an appropriate size collar when it's indicated. Secure the torso before securing the head. Then confirm that the padding and straps allow for normal breathing and adequate chest expansion. Many children around the ages 8 to 10 have proportions that are closer to those of an adult. But again, positioning should always be based on each individual child because age, again, you can have various sizes of kids. Okay. Infants and young children, again, still may still be secured to a car seat when you arrive, right? So their movements should be planned in kind of two stages. Removal of the patient from the vehicle, followed by preparation for ambulance transport, right? So when the seat and the built-in harness are intact, the car seat may sometimes provide a good support during extrication. Once a child is in a nice safe working area, transfer them to an approved pediatric SMR device. Again, that is dependent on your protocol. There's a lot of them out there. One clinician is going to maintain control of the head and monitor the airway, while the team just releases the harness and removes the child. Okay. You want to keep the head, the shoulders, the torso all aligned, then use the padding principles that we covered earlier to maintain that neutral position. Then, after the transfer, reassess the airway, the breathing, circulation, movement, sensation. Confirm that all the straps, the collar, the padding haven't been moved, and make sure the patient can still expand their chest. Our last section is on helmet removal. Okay, so when a patient is wearing a helmet, the decision to actually remove it begins with the patient's airway, their breathing. So you need to just ask whether the mouth can be reached, whether suction can be used, and whether the assisted ventilations would be possible if the patient starts to deteriorate. Now, with sports helmets, football helmets, removing the face mask may provide enough access while the helmet remains in place. You want to check the fit, right? A properly fitted helmet moves with the patient's head. If the head can rotate or slide inside the helmet, then it's allowing too much excessive movement and you should probably remove it. Then look at the relationship between the helmet and the shoulder and the torso, okay? The equipment should allow the head and neck to remain in a comfortable neutral position while SMR is completed. But again, the safest decision here is just going to be based on the combination of airway access, the breathing, and then the overall alignment of the head. Um, if the patient has a securely well fitted helmet, then it can typically remain in place when it's just helping control the head movement and if it doesn't interfere with patient care. But again, the airway has to be accessible, breathing has to be adequate, and you have to be able to assist ventilations if it's needed. Okay. The helmet also has to allow the head and torso to be secured in neutral alignment. This is where it could be kind of an issue. So if you see that the neck is pronounced in a flexion position, it might be more beneficial for the patient to just remove it. And again, a lot of football helmets you can just remove the actual face mask so you can keep the helmet on, which might be more conducive for a patient wearing pads like football pads because it'd be more in line. Okay. But again, continue your manual control while securing the patient, reassess. And again, if anything with their airway is compromised and you can't adequately treat and intervene, you're going to remove the helmet. So let's look at actually how to do that, right? So remove the helmet when it again interferes with your care or just isn't allowing for a secure stability of the head, right? A full face helmet usually is going to restrict access to the mouth, prevent suction. You're not going to be able to bag the patient uh, or create a good seal. Okay, so also, removal is going to be indicated when the face guard can't be removed and the helmet prevents neutral SMR or the patient head moves excessively inside. So, in the picture here, it just demonstrates how to actually take off. This is like a motorcycle helmet where the chin section surrounds the face and again limits airway access. A patient in cardiac arrest, again, is going to require immediate removal here. And then, yeah, so before you begin the removal process, organize your team, assign clear hand positions. The helmet removal itself has to be controlled because, again, pulling it off without coordinated support, that's going to cause manipulation of the cervical spine. So how do you actually do it again? It's not that hard. It does require at least two individuals. One person is maintaining control of the head and neck at every single stage. The first provider, again, they're going to be at the head open, and they're going to open the face shield and assess the airway and breathing if possible. Remove any type of glasses, the eye shield, and then the other provider holds both sides of the helmet with the fingers supporting the lower jaw. So really, you're going to be at the front of the patient. You're going to stick your hands in as good as you can, securing the area. You're going to have to unstrap the little chin strap if there is one, and then you're going to have another provider at the top of the head, and you're essentially going to try to pull on the helmet to kind of loosen it up. And then as you're taking it off, the other clinician is up here securing the head and making sure that the head doesn't drop backwards once the helmet is off. Okay. So remove the helmet fully, maintain manual stabilization of the cervical spine, and then again, after it's appropriate, apply a seat collar, and you're good to go. Now, yeah, so it's really not that difficult, but again, once you practice it one or two times in lab, you're going to have like a really good idea of how it goes. But be aware there are a lot of different helmets out there, so there's a lot of different configurations. So really be on the you're understanding the different type of chin straps and all that fun stuff. Worst case scenario, if you can't undo the chin strap because it's like a certain like it's tied together weird, you could just cut it off, right? But we want to try to avoid that as much as we can. Mainly because we don't want to like accidentally cut the patient, but then also destroy their equipment if it's, I mean, and we don't really care too much about their equipment. But really, it's just so we don't cut the patient. So that ends this very long chapter. I hope you got a lot of good information from it. And yeah, so practice is going to be one of the key elements in all of your EMT training, especially when it comes to your interventions. But there's so much that deals with the brain, right? So just like with our neurological chapters for pathologies was super long because it deals with the brain, so is the trauma, right? So the patient can present in a multitude of ways. It's very important to just recognize deterioration, understand how to do your neurological assessments, and taking very close care of any type of head injury, spinal injury, because it can have not only life and death implications, but also long-term disability implications. And sometimes that's just as worse. So again, hope you enjoyed, and I will see you guys next time.